Good afternoon, everybody. Welcome to this meeting of the Health Scrutiny SubCommittee. Before we start, I've got a few housekeeping arrangements. The meeting today is open to the public, so a warm welcome to all of you in attendance. My name is Councillor Ruth Milsom. I'm the chair of this subcommittee. A few bits and bobs before we begin. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There's no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present and the assembly point is in Tudor Square. The meeting today is open to the public and streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Can I ask that members and officers in attendance introduce themselves? Members first, please, starting on my left.
Thank you, Chair. Councillor Dorndale. Councillor Mary Lee.
Councillor Martin Phipps for City Ward and Green Spokesperson.
Councillor Sophie Thornton for Beechif and Greenhill Ward.
Councillor Steve Ayris, Councillor for Grace Park Ward and Deputy Chair of this Scrutiny Committee.
Councillor Anne Whittaker for West Ecclesfield Ward.
Lucy Davis from Health Watch Sheffield.
And our officers in attendance.
Joanne Cooper, Democratic Services.
Deborah Glenn, Policy and Improvement Officer.
Thank you. And just to say we have had apologies from councillors Talib Hussain, Laura McLean, Abdissam Mohammed and Mick Rooney. And today Mary Lee and Dawn Dale are attending as substitutes. So there are no items today that require the exclusion of the public and press. I think that's correct. Yeah. And then just to ask members if they wish to declare an interest in any of the items of business on the agenda. None? Okay, good. So we have then our minutes of the previous meeting, which is item 4 on the agenda. And I'm asking members to approve as a correct record the minutes of the last meeting held on the 7th of September. I wasn't intending to go through page by page, but I'll give you a moment, members, if you had any comments about the minutes. Everybody happy? Are we happy to approve those minutes? Thank you. Then item 5, public questions and petitions. Deborah, do we have any public questions today, please?
Thank you, Chair. We do have 2 public questions today. I believe the gentleman over there is the first question.
So I think it's Mr. Butcher, is it? Thank you for coming with your question today. Welcome. And I think your question relates to item 7 on our agenda, which we'll come on to very shortly. So we're happy to take your question now and invite those representatives from the Walk-in Centre to respond to that. Should there be anything else during the discussion that relates to your question, perfectly happy if you raise your hand for you to come in again. Okay, so don't feel this is your only chance to say anything.
Thank you very much. So my question is, on item 7, did you use service users as part of your mock inspection, mock secrecy? And was this people who use the service, or was it Sheffield Health Watch? Thank you very much.
Thanks. So I should have asked you to introduce yourself just before you speak. If you would just like to say who you are.
Hello, my name is William Dawson. I'm the Chief Executive of One Medical Group who run the Walk-in Centre. So the answer to your question is no, we did not. The mock inspection that was undertaken in partnership with Sheffield Teaching Hospitals did not have a layperson involved. They do have individuals called patient safety partners who are part of the new patient safety incident reporting framework, but they use those within hospital settings, not within the urgent care centres or walk-in centres. And from our own preparation work, what we have done is review the evidence table and questionnaires that we're supplied with through the CQC. However, we do use patient feedback, and part of the improvement process we have undertaken is speaking to patients who are using the service about their experience of the service during that time.
Thank you. Are you happy that that's answered your question sufficiently?
I am, Chair, but what I'm going to do, I'll talk to some other colleagues, service user, and if they think we need to bring it back, we will do. Thank you.
Thanks very much. I think we've had another public question, but I think it probably relates to our work programme, which we'll take later on in the meeting, if members are happy with that. It's a question asking us to consider something that would mean an addition to the work programme. So if members are happy, we'll take that later. Item 6 is members' questions. This is a fairly new item on our agenda and is a standing item that allows members of the subcommittee to ask questions of the chair if they relate to something that is not on today's agenda. I don't think we've had any members' questions submitted, have we, Deb? No. Just to be aware of that process for future as well. So, on to item 7, which is our walk-in centre update. And so I think we've got 2 people who have kindly come today to present an update and take questions. Just bearing in mind time, if you're relatively succinct with giving us the information you feel it would be useful for us to know, but bear in mind members will want to ask questions. So please introduce yourselves and let's have your update.
So thank you. My name is Dr. William Dawson. I'm a GP and I'm the Chief Executive of One Medicare, and I've got with me Rachel Beverley-Stevenson, who's the Exec Chair of One Medicare. We are the providers of the Sheffield Walk-in Centre. I assume that everyone has access to the presentation. I don't obviously have it, it's on the screen, but I don't have any clicker, so you're clicking. Do I just wave at you or nod and wink and something? Yeah. So nod and wink. So very briefly, so the walk-in centre has been delivered by One Medicare since 2009, and we do that in line with 19 other services, NHS services across England and Scotland. Next slide. For those people that don't know the service is a minor illness unit only, so it's a walk-in centre that provides unscheduled minor illness across the city, and also from people coming from outside the city. Next slide, please. And we have since, whilst initially commissioned by the CCG, now ICB, we're actually now commissioned by Sheffield Teaching Hospitals and work in partnership with them to develop the service. This has included introductions over the last year of a wellbeing hub to support with people's mental health, and continue to work with them around winter planning and making sure that the service delivers the care that we've been commissioned to deliver. Next slide, please. And next slide again, please. Thank you. So the service is open 7 days a week, 8 till 10, 365 days a year. On average, we see around 4,500 patients in the summer and about 6,000 to 7,000 patients in the winter. We're on average commissioned to see around 5,800 patients a month, but obviously throughout the year there is seasonal variation. It means that summer, sometimes such as October and December, that we see more patients than we would do perhaps in the summer. This is largely made more the case by the large number of patients who are students who are part of the service and live locally. So next slide, please. So we had in April the 25th, we had an unannounced CQC inspection. This was due to concerns raised by anonymous members from the service as a whistleblowing event. And this was around the historic performance around patients waiting in the service and the service pressures over the 6 months prior. These were issues that we'd already recognised and worked with our commissioners, Sheffield Teaching Hospitals, to address, and at the time the performance concerns that the CQC had shared and raised had been resolved. However, following the report, the outcome was that we were rated as insufficient in 3 out of the 5 areas, out of the 5 areas, so we put together an action plan in order to correct this, which ran from the 25th up until the 30th of September. So I can quickly go through some of the key actions that we've undertaken. If you next slide, please. So some of the elements that CQC found to be inadequate around governance systems and processes, particularly the clinical system that was being used. So we have worked with commissioners and our clinical system provider to update this, and that's been implemented since the 31st of July. This was largely around connectivity with the wider system, so clinicians could see patients' records and be able to undertake things like electronic prescribing. There was also a number of defects which in the estate which the CQC had found, which we have since corrected as well. Next slide, please. There were some elements around the implementation of existing policy and governance that we had within the company, particularly around incident reporting and lessons learned, which has been re-implemented within the service and to make sure that that's robust and sustainable. We've also reviewed the structure of the teams within the service to make sure that there's strong and supported leadership, and also a focus on clinical supervision, which was found within the report. Next slide, please. There were some elements of audits which the CQC found that whilst audits were being completed, not all of the learning from audits was being undertaken. So we've since implemented a new digital platform to review audits, which allows us to not only review but also triangulate the data from audits in order to have a much better oversight of the performance from audits.
It is worth saying that that was already underway, wasn't it? But
It was.
The inspection fast-tracked that.
Yeah. Next slide, please. There was an issue around the capacity for seating within the walk-in centre, and this was partly due to some of the distancing due to COVID and winter infections that we had in place at the time. However, that has been corrected. We now have a maximum of 70 chairs within the waiting area, and that's in line with fire safety regulations and in line with the expected volume of patients who will be attending the service at any given time. From last month, we have launched a patient engagement group in order to host meetings. This was something that was in place prior to COVID, but had to stop due to the pandemic. All of our staff are also completing mandatory customer services and conflict resolution training in order to support with better customer service from some of the feedback from patients. Within the CQC report was that patient feedback was mixed. So we worked to look at how we can improve some of that, and also made our complaints policy more visible to patients, so they now have cards at the front desk which have a QR code which take patients to areas to be able to feedback online. Next slide, please. One of the areas of concern was around wait times, and this had been largely due to wait times last year in September 22 and October 22, getting longer at the point of time we weren't meeting the KPIs for the service. There was a plan at the time that was put in place, and by the time that the CQC actually visited, we were complying with the KPIs within the performance wait time, and that was from March this year onwards. However, it is acknowledging at the time of significant pressure within the service due to initially the Scarlet fever outbreak and then winter pressures that we weren't meeting those KPIs. At the moment, I think we have at the time of writing this presentation, certainly the percentage of patients who were being seen within and discharged within 4 hours was 96%, and the percentage of patients who had a clinical consultation within within an hour of booking in was 94.4%. Next slide, please. There was also some concerns around staffing capacity, which has been raised from locums who were in the service at the time. We have reviewed the staffing capacity and capability and are confident that actually the model reflects the right number of staff that we need in order to see the patients who come through the door. This is done in a number of ways. So we use data from the last 5 years of the contract, excepting for the year of COVID, to review and track what the predicted daily activity will be within the service, and use this as a starting point to look at clinical workforce. We have within the service now GPs who oversee all of our care for paediatrics, advanced nurse practitioners, advanced clinical practitioners and physicians associates working in MDTs in order to make sure that there's resilience and safety when seeing patients. Next slide, please. Now, this is something, so when we're looking at staff capacity, we look at this every month to make sure that the workforce is appropriate for the patients who are coming through the door. The aim is to be able to meet the KPIs within the service of patients being seen within 2 hours and 4 hours. We've also got training plans in order and recruitment plans to bring more staff into the service to replace the contracted locums that we use in order to give a better standard of care. Next slide, please. Some of the feedback from the CQC was that we weren't spending enough time doing clinical supervision. We feel that there is some definitions which were unclear at the time of inspection around clinical supervision. And for those that don't understand what clinical supervision is, so there is informal clinical supervision, which is more around team support. So as a GP, you may be supporting a nurse or where you're not sure of a case to go and talk to a fellow clinician. There are some requirements from nurses within their revalidation around having regulated clinical supervision on a quarterly basis. So we can confirm that all of our clinicians have documented and formal clinical supervision on a quarterly basis. And we've also put more in place to make sure that informal supervision and support is available. So all of our teams have twice daily clinical huddles where they can discuss cases and review the performance of the service. We also have 2 circuit breakers throughout the day where clinicians can come together to discuss cases and have an open door policy. Within the current team, we also have split it into a series of micro teams where every clinician has a supervised senior clinician which they can go to and ask advice at any time. Next slide, please. There was also a comment around not having the appropriate freedom to speak up guardian policy in place at the time of the CQC. This is something that we did feel we had in place, but we've reviewed our policy and the structure of it and have made that and reshared that with teams and run the training so everyone is aware of that, and so that is visible within the service. Next slide, please. As we have in the aforementioned Wellbeing Hub, which reviews, supports patients with the wider determinants of health and social care and also mental health. That Wellbeing Advisor also supports as a Wellbeing Ambassador and supports our staff internally and hosts a quarterly Wellbeing event where the team can speak to each other and the Wellbeing Advisor around any concerns they have around their wellbeing. The team also have access to a national on-call Wellbeing Advisor should they have any problems with their own mental well-being. Next slide, please. Following the CQC, we've also reviewed our infection protection and control to make sure that the cleaning and cleanliness and the infection control within the service is adequate, and that's been part of our reviews and mock inspections. Next slide, please. And as mentioned within the question earlier, Sheffield Teaching Hospital's quality team have undertaken 2 quality reviews over the last 6 months within the service to check on progress that we've been making. And the One Medicare senior team, including clinical leads and quality leads, have been on site on a weekly basis and operationally on a daily basis in order over the last 6 months to make sure that the service improves in line with what we would expect it to. And that's the end. Thank you very much. And take any questions that you may have.
Thanks very much indeed. I've got Councillor Phipps and then Councillor Ayris and Councillor Whittaker.
Thank you, Chair. I just wanted to preface a few questions that, as a councillor in the City Ward Council in particular, I am grateful that we have a walk-in service. And I just wanted to start by thanking everyone who works there, because it's a service that I'm glad that we have. Lots of City Ward residents use it, as I have, and in particular students, as you've mentioned, and also some really vulnerable people, such as those sleeping rough use it, so I'm glad we have it. And I agree at the end of the report where it mentions that it's a key community asset. I do agree with that. So on point 3.3, of the report, and the CQC recommended action on improving confidentiality at the reception desk when supporting patients who are unable to complete the arrival forms themselves. I can't see an action that's been taken to address this. I might have just not seen it, or is this something still to be done?
So it's something that's already been completed and was actually part of the inspection. So we have a confidential room which is next to the reception in order for patients who do wish to speak privately, and that is available to them. Do have screens up, and that's the nature of the sort of due to infection control post-COVID, which means that actually patients are unable to sort of lean over and speak in private at the reception desk, but there is the availability for them to have a private room should they wish to speak in private about what they're seeing.
Thank you. And I was just on that seating number for 70 patients, is that proving to be enough? I'm just conscious the last time I went, there were a lot of people that couldn't get a seat. I was sat on the metal kind of railing at the back.
So on average, we have about 30 patients an hour. So on the whole, we tend to have no more than 50 people in the waiting room at a time. It's also in line with what's safe from a fire safety point of view.
Okay, and we're finding at peak times that 70 is okay. Okay. And just one more. So I know you said that for 96.4% of patients are having a clinical consultation within 60 minutes, which sounds good. I just wanted to check what constitutes a clinical consultation. So when I visited, I had a triage within 2 hours, and then actually saw a healthcare practitioner probably another 2 hours after that. Would that count as the first triage, that clinical consultation, or would that count as the second?
So no, that's the clinical triage should be happening within that time. So it's a clinical consultation is actually your final consultation from that point of view.
Okay, thanks. That's really useful. Thank you, Chair.
Councillor Ayris.
Thank you, Chair. Thanks for the report. I've got 2 questions. The first of which is, do you does Medicare hold data on where geographically your patients are coming from? And if so, does that indicate a particular geographical area? And basically, why do you think that is? What does it tell you if you have that information?
We will have that information. It's not information I have to hand, so I can't answer the question, I'm afraid. But we can follow that up and give you that information to the committee if they need that from that point of view. That's something that we report to the commissioners as well, so it's visible across the system.
Yeah, thanks. If we could do that. Thank you for that. Second question is, I see on paragraph 3.4, it talks about the legal challenge to the inspection and mentions the containing a number of factual inaccuracies, the overall findings, hence your legal challenge. But the report's unclear as to which aspects, One Medicare are challenging. I just wondered whether you could just elaborate that where you think?
Yeah, so in particular the 2 warning notices. So we have challenged those legally, and we've had communication from the CQC's legal officer yesterday. They've been very slow to respond. We have fed back, we have a relationship manager within the Care Quality Commission who has been working with us, and we have fed back to them right from the beginning that we didn't agree fully with the inadequate rating. It's not that we don't acknowledge there were some areas for improvement, which hopefully we've addressed throughout this report, but we do not feel it is an inadequate service. And in fact, recent inspections, including with our STH colleagues, have confirmed it really should have been rated good. However, it is what it is, and we're not trying to be defensive or row away from that. But in terms of a legal challenge, it's particularly the 2 warning notices that we have evidence to prove were incorrectly issued. So that's what we're challenging on.
So I think just to add on that, from as a national provider, what we see is we have 5 different urgent care centres, and what we see is different ratings applied to different areas of what is consistent delivery from our side, depending on the regional nature of the CQC. So some of that is around the inconsistency that we have within inspections. There are some elements as well which we feel that they have incorrect. So at the time of inspection, we were given incorrect advice around this freedom to speak guardian governance. And so there is an element of what the individual's preference and best practice was within the inspectorate at the time were compared to what is actually kind of nationally mandated. There's also some elements around understanding the service that we have around key recommendations around what we do with locums. So there was a criticism that we're not supplying our locum staff with equipment, but actually from a legal point of view and from a sort of tax point of view, that we're due to the changes in tax law around IR35 is that we cannot supply independent contractors with any equipment, otherwise they become employees. So there's elements like that which we have to go back and try to correct them on. The reason that we've moved forward with the legal challenge is there is a process within the CQC where you are able to challenge the draft reports. Those initial challenges were ignored. So that is why we've extended it beyond where we would do normally.
Thank you for that clarification. Thank you.
Councillor Whittaker.
Thank you, Chair. There's 3 questions, but they're all on the same sort of topic, so I'll do the 3 questions and then you can answer them one at a time. The report, well, thank you for the report. The report talks about staff having 8 AM, 12 PM huddles, about circuit breakers. How realistic is it that staff will actually get the opportunity to attend those if you've got a really, really busy walk-in centre, you've got lots of patients waiting? So it sounds really good in theory, but does it work in practice? What percentage of staff actually do attend those huddles? So however many staff you've got on in the day, how many attend? And if a staff member is consistently unavailable, so consistently can't attend huddles, how do you follow up with those members of staff?
Sure. So yes, in short, they do attend. They do occur. They tend to be sort of 15 to 20 minutes, and within the structure of the day, there's actually no reason why those can't happen. So they're mandatory for all staff. Part of that is around actually being able to review the flow of patients and the actual activity of the day. So having been there, they're well attended. Even if there's 1 or 2 people who are stuck with patients, what they tend to do is then come as soon as they've finished seeing those patients. So yeah, those do happen. I think they're really important that they do happen because they have not just source of benefits for the staff around connection, but it's also really key from a performance and governance element of it. So they are part of the management team, make sure that they occur, and they're led by the management team from that point of view. For staff that can't make it, so it may be patient staff who are off as well or are not on shift. So all of those notes, there are recorded huddle notes which are available within the service in paper copy and also available on the internet, so people can access them online as well.
Thank you. Can I just ask another quick question? In terms of complaints, are the figures available as to how many complaints you get per week or per month? And is there a common theme? So have you got one theme where, that gets the most complaints on?
So we can get you those, don't have those to hand, I'm afraid. The most common elements are complaints around staff behaviour, and commonly as well is around the amount of time that patients have been waiting in the system. What we see from the feedback we've done over the last few months is the most common reason for patient dissatisfaction is not so much with the walk-in centre, but the fact they've been waiting for an appointment through actually not being able to get a appointment with their GP, then waiting a long time to see to speak to a patient on NHS 111, and then actually having to then be told to come to the walk-in centre. So actually a huge amount of the complaints actually we aren't directly involved in, but the majority theme around the complaints is around staff behaviour, which is something that we work on, but is obviously a huge challenge for staff who very easily can get burnt out, very easily have that sort of empathy drain that comes with the NHS at this point in time.
Thank you. And then obviously that affects their behaviour if they're, yeah, so that's, thank you for that.
I can see Lucy from Health Watch is nodding vigorously. You did put your hand up, Lucy. I'm going to bring you in next. I don't know if you've got any comments about that.
Yeah, the question that I was going to ask actually follows on very directly from that. So at Health Watch, we do obviously get some feedback about the walk-in centre, both positive and not so positive as you'd expect. But most often actually we hear about people's journey through primary care and hear the walk-in centre as one part of that journey, and their frustration is very much the overall picture of the delays and the difficulties that they've had getting the treatment that they needed. So I was just going to ask a question about how you're linking, like how you collect information on that. What information do you get that would help build that picture of, the journey that people have had, or the kind of, I guess, linking back to Steve's point about where people in the city might be coming from. So identifying then where there might be particular areas where people are having extra challenges. So how does all that information kind of get put together and provide learning for the wider system, because you're kind of on the front line of that experience, but actually the sort of issues that you're dealing with day to day go sort of beyond, what's coming through your front door. I did have another question as well. Do you want me to come back on that, or should I?
It does, yeah, it does. I think we obviously work with commissioners, both the Sheffield Teaching Hospitals and the ICB around some of that. I think a lot of the information you're talking about is triangulating more through the primary care sort of delivery team in the ICB, which we're not always naturally kind of linked to. And again, there's obviously wider sort of providers within Sheffield from primary care point of view that we don't always have the same connection to that we would perhaps in other parts of the country. I think what we do see is actually there's what is fed back very anecdotally is around a greater kind of push, a greater need from patients who are coming with more complex conditions which we'd normally expect to be seen in primary care, or patients who are coming from services that have been commissioned in primary care, such as the management of asylum seekers and some of their kind of care as well within the asylum, sort of where they're housed in within hotels from that point of view. So it's some work that we need to do more as a service to connect in with the primary care. So we do report back around sort of activity data, so primary care commissioners can see where the sort of highest frequency users are coming from, which sort of general practices patients are using the services more than others perhaps. But it's more work we need to do from that point of view, Lucy. I think there's the other element from a Health Watch point of view. We have had Health Watch come and do it in sort of official inspections of some of our services as well, and put reports on those. So we'll be welcoming of that as well.
Thank you. Yeah, it strikes me it's not just your work to do in that sense, it's a kind of system issue. But can I just briefly come back with my other question, Chair? Is that okay? So the other question that I had was just around the patient engagement group that you mentioned, and sort of, I guess, building on what the public question that we heard earlier. You've talked a lot about feedback and learning from feedback and so on, but I was wondering whether or not, if you could describe a little bit more what that patient engagement group looked like, and whether or not there was going to be a role there for patients to sort of directly inform improvement rather than just kind of give feedback and then walk away, but actually to be involved in the improvements.
I think traditionally sort of patient engagement groups within urgent care are very difficult because obviously it's not a registered population, it's a transient one. What we're seeing within the new framework around investigating incidents, so the patient safety, try and get it right, patient safety incident response framework is these roles of patient and safety partners, which I think have a key role to play in some of that, because what we don't want is people just to come and kind of, as you say, give their feedback and walk away. It's around the elements of engagement. So that's something that we're working on. I think we're keen to work with bodies like yourself to make sure that we are getting that feedback, which we can be actionable as well, because again, often what we get from feedback is people who have gone through the system and are kind of at the end of their tether, really. So some of that's not always, whilst it's very sort of visceral and sort of real, it's not always very sort of productive from being able to change things point of view.
There are softer ways that we engage as well, though, through the wellbeing hub that Will mentioned, which has a dedicated advisor who does quite a lot of reaching out to different groups. And this is where we would just lay open a wide invitation for any groups who want to connect with us as a service. We're very open to that and really would welcome that. We are a city-wide service. We will get you that data around where the frequency and the higher volumes are coming from. But we serve the whole city and we want to connect and respond to their needs. And just historically, prior to COVID, and looking at Kate without putting her on the spot, we did used to have more system-wide meetings, but where primary care and urgent care was party to those, but because of a pandemic they stopped, and I think it's finding different ways of us to communicate across the system.
Councillor Thornton.
Thank you, Chair, and thank you for the report. I can echo what Councillor Phipps has said, and that it's obviously a service that we all will probably have benefited from at some point, and it's been a positive experience for me when I've come in the past, so thank you for that. I do have a few questions, so do bear with me. My first kind of leads on a bit from what Councillor Whittaker and Lucy were saying about the being able for staff's freedom to have the time. And I think that there's a lot in the report and a lot in the presentation as well about time, you know, what training and the encouragement to undertake university modules and things for staff, but not necessarily so much within the report about how the actual time is protected for that. I was hoping that you could talk me through how time has actually been protected for staff to do it, because on my reading anyway, it felt that it was on top of everything else that staff had to do.
Yeah, it's a really good point. So we have within the service a clinical educator who is sort of on hand, and part of their job is dedicated non-patient facing time to be able to develop some of those processes, and a lot of that is then around how we sort of make time through effectively double running with staffing in order to take people out of the actual day-to-day service to be able to sort of run training modules and things. So we have some examples where we've been running individual sort of groups of training within the service from that point of view. We have run, what we run also is a clinical practitioner program. So we actually employ sort of junior staff or those who are on preceptorships from hospital who come actually across, and part of their contract is to be able to have some of that learning time within it in order to be able to go away and do some of that training, and some of that is they work supernumerary, so that's in additional to the existing workforce, so it can be more of a learning nature. I think, Sophie, it is really a challenge, because often that comes with it, obviously putting staff through that has an element of cost to it, but it's also acknowledging as well around actually building that workforce, and you need to have that sustainability and retention, so it is that sort of investment in time. So again, it's around having the supervision, so people are not actually necessarily having time actually working, seeing patients. They have that time out, which is scheduled. So I think if you try to do it informally, it doesn't really work, because actually people never find the time, because the service never, there's never a quiet period. I think the challenge around some of those is because it's different to a hospital, so we're not a 24-hour service, so we have a very fixed time of which people are working, and so that makes it increasingly difficult to spread out workload from that point of view. So it is around, in some cases, then having different degrees, and that's where the MDT that we have within the service is so important. So we have the senior GPs who can oversee and supervise, when we have some of the juniors who are restricted on their practice, but have more time out to be able to actually develop those, and in time then develop into more competent and more sort of senior clinicians as part of that.
Thank you. I suppose another question follows on quite nicely from that, as you mentioned about retention, with what your turnover rate looks like in comparison to what it would have looked like at the start of this year.
Yeah, it's a good question that I can't answer at the moment. I don't have those details, but I think what we have seen over the summer is a much quicker sort of recruitment period, and I think that happens in some ways just through the sort of seasonality of recruitment and people qualifications from that point of view. We tend to have we've had a sort of fairly, without sort of saying, we've had a much sort of improved retention rate over the last 6 months. I think, as far as I'm aware, we've probably had 2 people within their sort of first 3 months who decided actually that it wasn't the role for them. We've got 1 GP who's moving to Canada, which we can't really do anything about, unfortunately. But we have had lots of sort of positive recruitment as well, and actually today we're having a recruitment sort of open day as well within the service, and having a sort of interview day. So we again can look at the return, give you the turnover over the last 12 months. I'll take that away and give that information to you.
Yeah, thank you. Next was about the surges in demand, and I think that's been touched on quite a bit. The report talks about the daily situation reports and how that's escalated through a framework, but can you talk me through what happens when there's a surge in demand on the ground and how that's actually enacted, and what would it look like on the ground when there is a big surge in demand?
Yeah, so I think surge in demand, I don't think they don't necessarily happen from a day-to-day point of view, but I think we can expect that, and what we try to do is track the data, so we know actually when we get into November and December, we'll see probably about 1,000, 1,500 patients more over that month than we would do on any other month, so it's around that sort of pre-planned staffing. As far as the contractual elements of it, we're not, as a service, we're obliged to see every patient who walks through the door and manage them safely until the time ends. So we don't have and one of the misconceptions, which is often shared, and I think is probably normal practice in other services from an urgent care, and so is sometimes sort of raises concern from staff, is around the idea of a closed down process, the idea that when it gets busy, that we turn patients away, or that when it's time to close, we send patients elsewhere. We're not contractually allowed to do that, so we have to see the patients that walk through those doors. So then some of that is around sort of effective staffing throughout the day to manage patient flow, and I think there's important elements to see. What we see in Sheffield is we see sort of a mid-morning peak and then a mid-afternoon peak. After 6, we tend to have quite a few patients. We probably only get about 30 to 40 patients coming through the door. However, it's how we manage the shifts over the whole day, which is an important element to it. When we do have staff sickness, if we do have shortages, what we do is we have a reporting system which aligns to national frameworks, which has a set level of escalation around how busy we are. So it's sort of staged in 1, 2, 3, 4, and depending on how serious it is, there are documented actions for the local team to take in order to help mitigate those. Some of those include contacting the senior team, and some of it will include finding additional staff in order to accommodate that, particularly where there's been staff absence, and from that point of view, we have a workforce team and a resource management team that kind of works solely on making sure that the right staff are there, and if there's anyone that's causing sick, or if we need more staff, how they source those through temporary agents who work.
Thank you. And then I've just got one more question. It's mentioned that there's been senior leaders from One Medicare centrally placed within the team to oversee the recovery. I'm assuming they're not going to be there permanently, and if so, what discussions are taking place to ensure that smooth handover and that things don't fall apart once they leave?
Yeah, I think the key for that is they're there to support the team and build the team up. It's not around building the team around those, because I think that you're quite right. From a senior leadership point of view, they've been there to support and make sure that the service has the right stability. We are in the process of recruiting a new operational manager and clinical lead within the service. So what we've done is had experienced senior leads who have done that job previously present to make sure that service is stable whilst we're recruiting for those. There'll be a period of probably about 3 months then before those people bed in, and And what we do for all new employees, they have sort of a 3-month sort of onboarding and then a 6-month review as well to make sure things are working from that point of view. So it's not something of just handing it over. I think that's absolutely right that the sustainability of the work that we do is the important thing. It's not just about making sort of ticking, sort of patting ourselves on the back and saying we've got to where we need to get to. It's about following it through from that point of view. But we've got a very hard-working senior team. So I think that, for example, today we have our sort of lead for governance and quality, who is a previous service manager at Sheffield, who's been supporting the team, and one of our planning leads, who is acting as operations manager, and got the director of workforce and the head of recruitment who have been there, and they've been there sort of regularly as well to make sure that we're not just looking at the people, we're looking at the processes, we're looking at the people as well.
And added to that, we have weekly executive committees where all sites feed up into the exec, and they're chaired by myself and our vice chair. So we look at all of the quality indicators and performance indicators and put any actions in place that are needed. So they're really about quick decisions so we can support the sites. So we have that extra layer of governance also.
Thank you.
Councillor Lee.
Thank you. You've touched on some of the questions that I wanted to ask so far, but just for clarity, I'll ask a few of them or just expand on them. In terms of supervision, you said in the report that there's quarterly supervision for clinicians, and then the huddles, which are also supervised, that's supervision as well. Are all those recorded? Is that what you said? And also, the quarterly supervision, is that on par with other clinical settings of a similar nature?
Yes.
It is, and everything's recorded. Okay then. And you've said in the report about extra training, and staff are encouraged to go to the university to attend lectures or other types of training. Is that training paid for in terms of those hours that they're out doing that training? Those are paid hours.
So we fund some of that training. So that's around staff taking on core sort of modules around clinical practice or doing their advanced practice. So that's funded from within the services. Some of that's done within their own time. Some of that's done within contracted time, and that depends on actually the hours they work and the actual availability of those courses. But we will fund and support, for example, a nurse to become a nurse prescriber.
So when any training they feel is relevant, that will be paid for, apart from the in-house training?
Yeah, I think there's sort of elements. So we often talk around sort of what we mean by training. So I think there's a few. So there is mandatory training, which all staff have to conduct from that point of view. There's self-directed sort of learning, which is part of your professional practice, which is where people will learn themselves in their own time from that point of view. But where we have formal training around formal skills, within relying to their roles. So, for example, a nurse who wants to do their sort of respiratory module for their advanced practice or their non-medical prescribing, then that's funded. We fund those based on a sort of a request within their own personal development plans.
Okay. And just lastly, I guess, in terms of the culture of the organisation or the culture of the walk-in centre, if people in the first instance felt they had to complain to an outside body, then the culture wasn't right. The culture, do you think that it's very difficult to change culture? It's very hard to know when it's changed sometimes, but do you think that is something that you're working on as part of this process, which I think sometimes is very hard to define in terms of what the culture of an organisation or work setting might be, but we all know what we mean by it.
Yeah, I couldn't agree more. I think the culture element of it is a big issue within the NHS. I think and you're right actually, I think within every service as well, the subcultures that exist in those can be very difficult to change, and sometimes actually it's about how you kind of modify it and bring those forward. I completely agree. I think we got the culture was not one where people clearly didn't feel psychologically safe to be able to speak out, and I think there's some work that we need to do in order to improve that. I don't think that's unique within healthcare. It's something as an organisation that I personally very much champion around the improving the sort of compassionate and transparent leadership elements of it, and the freedom to speak up element of it. I think it's worth sort of saying that annually and in the last month we do a board-led well-led peer review to see whether or not actually the culture and the systems that we have promote safety and promote that psychological safety that's needed from that point of view. Because it is something that has to happen from the top, and people need to be able to feel sort of respected and comfortable and safe at every level in order to be able to do that. So that's something that I take very seriously, and it's something that my colleague, who's the Director of Workforce and Culture, works very hard with as well. But yeah, it's around sort of mutual respect and value, and people being able to feel safe that they can speak up without fear of being punished or criticised or blamed is really key. I don't think that's a unique issue that we have, but it's something that as a smaller organisation we work really hard to make sure we improve on it, and at this point we didn't get that right within Sheffield.
So I think if people feel that the culture is right, they feel they can invest in that in the organisation and the setting, because organisations can be big, but a setting can be just one place. So I think if the culture is right, then people will invest and will speak up and feel that they're speaking up as part of the investment they're giving to that particular organisation.
Yeah, absolutely. No, I completely agree as well, and I think that's something that's often within any improvement. I think the temptation to sort of point the finger and say who's to blame is natural, but always the wrong one. And then I think also the sort of very nature of improvement has to happen through a culture where people feel safe and supported and actually buy into that. Otherwise, that change doesn't happen. So yeah, absolutely agree.
I've just got a couple of questions myself. Lots of my questions have been asked already, which is brilliant. And I wanted to say thank you for hosting me and I want to recognise that you did write proactively to councillors and notify us that CQ inspection had happened and what you were already doing about putting an improvement plan in place. And you did invite members to come down and meet you, which I took up, and I was very grateful for that and the time that you gave. So thanks for that. On that visit, and you showed me around the wellbeing hub, which does seem to be a huge asset actually to the facility and what's on offer for ad hoc access to primary care in the city centre, well, for the whole city. So I just wanted to hear a little bit more about why you started up that service. What was the perceived need? Was it responding to need and demand, or was it a proactive thing that you did? And how uptake of that service has compared with any expectations that you had? And also, is that a model that is observed elsewhere in primary care settings? How unique are you in offering that? And is it something that you feel could be scaled up to provide more capacity for that kind of service in Sheffield?
Yeah, so I think wellbeing and the sort of proactive social care elements have been part of the company's sort of DNA since Rachel started the company. So it was some of the very first primary care services that we had patient education centres, particularly in deprived areas. So it's been very much at the heart of the delivery model that we've always had within the service. I think whilst it almost feels counterintuitive for it to sit in urgent care, actually we know that a huge amount of people who are coming into urgent care have more chaotic lives. So as you imagine, people that, for example, who have no fixed abode, but also people who come from ethnically different backgrounds as well. So it's a model that we put in place probably about 4 years ago in another urgent care centre. And the key around that was for patients who were coming in to be able to offer them somewhere which they can have a bit more time to talk around sort of the wider problems that they might be having around health, and also from a mental health point of view, recognising and being able to say that anyone who's sort of worked in A&E or worked in general practice can say that a huge amount of people come through and you do very little with them from an actual medical point of view. So it's recognising that there are non-medical care needs that people have when they present in an urgent care setting or an unscheduled care setting. So it's something that we worked with Sheffield Teaching Hospitals to pilot, and we were really grateful for their support and had a very positive and had some external funding to support with doing that as well. And we've had some very positive findings. I think we had over 1,000 patients in the last year. The aim was for 2,000, but that was more around a capacity staffing capacity rather than actual patient need. We feel there's more that can be done with that. It's something that we have embedded within our urgent care centres and in some of our primary care centres. Some of that has played into the sort of, because of the wider working that now happens within PCNs from health and wellbeing, sort of health coaches and social prescribing. I do think there's probably limitations to what social prescribing is about. I think the very term social prescribing gets it wrong because we're trying to medicalise something which is non-medical. So the actual approach is not about socially prescribing things. It's about helping to empower and give be advocates for patients within a setting where they're struggling to access services and struggling to be heard within services. And I think, you know, thinking very much around sort of making every contact count and patients' need in a slightly different way, to say actually sometimes we try to pigeonhole what patients' need is, and if it doesn't fit we kind of dismiss it and it goes somewhere else and sort of goes in this sort of washing machine, kind of tumbles around. So the wellbeing hub is really trying to adapt to that, to try and sort of support those patients, acknowledging those patients will go somewhere eventually and they will probably go to A&E eventually as well, and that's not really what we want them to do.
And just building on that, it's evolved over the years. So we have had patient education and patient advice built into Sheffield and all of our services since the get-go, really. And Rob, who I think you met when you went to the visit, he started as a receptionist, and he's an example of actually how we do develop our staff and train them and help them grow. And he has a real passion for connecting with the rich assets that Sheffield has as a city in terms of community support and all of the third sector. So we've really built, through his energy, built the service from there, the wellbeing hub. But as Will said, it's something that's across all of our sites in one form or another.
I think there's the element of outreach, which has been always quite present within Sheffield. So there's always been around a lot of outreach to educate children within primary schools. There's been work to support with sort of men's health within key demographics as well. So it's an element of outreach which I think is slightly beyond what people would traditionally think of as an urgent care centre, but it's sort of acknowledging the use that they can have as a community asset, really.
Thanks. Just a very little question, and did notice in the report that it says that patients are attending from out of area, including Rotherham and Chesterfield. I'm just really curious as to why patients are attending from those places.
I can't answer that question because I don't know, because we don't actually ask out about why they go out of area. I mean, we do see in the majority of the urgent care centres that we run, they're cross-boundary travel, and that's normally to be able to get somewhere where they can get access to care quicker. So it probably says around the sort of pressures and weights, but I think to give you an idea, when we the services we run in Leeds see patients from Bradford and Wakefield. The service that we run in Corby, which is near Kettering, sees patients from Leicester. So it's a common occurrence, and there's a contractual sort of mechanism to make sure that that's sort of married up. So the local area doesn't pay for those patients; they're paid for by we have to invoice the areas where the patients come from. But it's normally anecdotally, because patients know that's a place that they can get seen sooner than they would do than their local area.
Thanks. I don't know whether maybe I'm looking at Kate here. Maybe there's a bit of a line of inquiry to go behind that as to why patients might be coming from other places. Is it just that they happen to be visiting Sheffield on that day, or is it that they're specifically coming because they can't find the care that they need nearer to home? It's maybe something that could be looked at if you're not already.
Yeah, I think certainly historically pre-COVID, a lot of the activity was due to people actually working in Sheffield. So it was easier for them to, walk in at the start or the end of the day or in their lunch break rather than try and travel home in the middle of the day to attend a GP appointment. But it's something that we can keep looking at again now.
And then I've got one more thing and then I'll shut up. So this isn't a negative story, but it starts with a negative thing. So on the 5th of December last year, I walked in to the walk-in, and I came because trying to get a GP appointment for what I wanted wasn't going to be quick enough to reassure myself that I wasn't becoming very ill. I had a throat infection, I'd lost my voice. I never lose my voice, sadly for other people. But I had on that occasion, and it worried me. I was worried enough to seek some help, but it wasn't urgent enough for an urgent appointment at my GP. So I used the walk-in, which I've used before, and not waited very long at all, and been really happy with the service there on a couple of occasions previously. But on this occasion, there was a 6-hour wait. And it was, I think, whilst strep was kind of coming into full bloom, and what I saw in the waiting area was chaotic, and that, you know, there were people looking pretty desperate, and there were people with young kids who were, you know, all over the place. They looked as though they were at the end of their tether. And my first thought when I walked in, quite frankly, was a cesspit of infection. Do you know what I mean? Like, I felt really freaked out by the amount of infection that was in that relatively confined space. I guess there's a question about infection control, and when you have got a surge, and as Sophie alluded to, what is the forward planning for surge management? Like, have you got any plans, having experienced that kind of surge, and what happened on those days? Quite aside from the 6-hour wait, which is obviously quite distressing for patients. Just that sort of chaotic environment. I know you've put more seating in, but I think there were probably more than 70 people there on that occasion. And I think it's the fact that it was a lot of kids, so when it's an infection that's spreading amongst children, and you've got that environment, that it wasn't a suitable environment for a lot of children to be in and waiting for that kind of length of time, and families to be trying to manage that situation. So do you have any plans for kind of an overspill for big surges, and how to manage that in a physical capacity kind of sense? And really, I mean, it just got me thinking, you know, all sorts of stuff about the service. And I was really glad that I came to see you that time, because it was much better on that day, wasn't it? Only a few people in the waiting area. But it would be nice to think that one day all parts of the NHS have got enough capacity to not ever be in that kind of position. And I mean, obviously COVID showed us a lot of that, didn't it? How not much of the NHS has got that. And I don't want to call it a luxury, because it shouldn't be a luxury to have the amount of capacity where you can actually provide for, you know, all but the most unimaginable circumstances. So what would be kind of your dream position in terms of capacity? If there was no issue of resource or staffing or anything, what would be your sort of dream position? What kind of numbers would you like to be able to receive into the walk-in centre? Or is that the wrong question? And should we really be looking at other parts of urgent care and primary care to relieve the pressure from you?
I think it's probably the right question and the wrong question in certain instances. So I think the role of urgent care, I think we need to think really carefully about what that means, because part of what urgent care does very well is to support with the pressure within the emergency department and support with the pressure within general practice. And I think that's quite right, because the emergency department needs to be looking after people with life-saving conditions, not people who've come with scabies. And equally, general practitioners need to be keeping people well and managing people's long-term conditions so they don't get sick, so they then don't need to go and see somebody. So actually them seeing kind of 45 sore throats a day isn't great, because actually that means they're not looking after the people who have uncontrolled diabetes. So I think urgent care plays a really important role in helping people, such as you mentioned, to get urgent care when they need it, because actually if they don't get urgent care then, they're not sure what the consequence of that sort of delay will be, and I think that's a very important role that urgent care has. I think we're contracted to see about, on average, 188 patients daily, so sort of capacity to see 200 throughout the day is probably what we look for. That depends on the kind of productivity and the sort of availability of staff. I think from a space point of view, I don't think we adapted well enough to those changes in that unsort of planned demand. I think and I think one of the consequences of COVID is that we started to manage sort of care very differently. So we didn't want people in those sort of spaces. So we kind of almost made it very hard for people to be able to kind of congregate. So, you know, if that had been COVID, those patients, we wouldn't have allowed those people into the service. They would have had to wait. We would have given them an appointment. We would have had sort of different settings. We do have enough space in that waiting room to be able to sort of turn it into sort of hot and cold areas. So we have an upstairs waiting area for people who might be vulnerable from a immunodepressed point of view, and we've also got the other areas. But we do, as you say, have limited area into that waiting room, and if you're not going that, but then the service scope is around minor illness as well. So a lot of the majority of what patients will come with some form of communicable type disease. So I think there's an acceptance that there will always be a certain degree of that. We're not in a position where we're distancing people, so a lot of it comes back really to actually sort of patients flow throughout the day. So from the 14 hours that service is open, is how we can manage the peaks and troughs of those people, that 188 people a day coming in, because actually often the waiting room is full not because people have all arrived at the same time, but it's actually people have built up. So it is key to make sure that actually we're seeing those patients in an efficient and effective way throughout the day in order for that flow to work. And I think sometimes when we get our patient flow wrong, and that can happen through a number of different ways. Sometimes it can happen because there's not enough staff, but it could happen because we've got an emergency. Someone could fall down the stairs outside, or someone could have a heart attack, and actually that slows how quickly you can see other patients. So you do get build-ups. I think part of the work we do is to make sure that patient flow is really effective in order so we're not having too many people waiting. I think the problem with that sort of last year was actually we had a lot of unexpected sort of paediatric conditions, which meant that actually which took longer to see than we perhaps predicted to see that. And I think that data sometimes just isn't predictable. I think that was one of the issues with COVID. It wasn't predictable. But I think the learning from that is making sure that we've got enough resilience in the system, in the team, to manage that patient flow. So actually we aren't getting to the point where there's a huge amount of people waiting in the waiting room, and we've got better at that over the last year. I think we need to focus and make sure that we continue to do that throughout winter, because this is the time when it will get busier. And again, I don't think we won't be the only waiting room that will feel like that over the next 6 months.
If I can just come in from a more practical built environment perspective. So when the walk-in centre was first commissioned back in 2009, some of you will remember the building was a shell that we then, with our property arm, because we have a property arm as well, fitted out into an urgent care centre with a co-located GP practice at the time, which has since moved out. The space was designed for 36,000 walk-ins. It's now doing more than double that. So there is a practical piece that we have been working on with our property colleagues and with our landlord around how we can improve the built environment and the care environment, and that's still ongoing. One of the challenges, which people may or may not be aware, is that the contract isn't forever, so it does have endpoints on it. And because there's been lots of system redesign, COVID hasn't helped either, and this is not a Sheffield unique point, it's happening everywhere. We haven't always known what the future of the service was, so that does make it harder to make those changes. But everything you've fed back to us is acknowledged, understood, and will feed into the work that we're already underway with. There is some spare space there that is a shell that was never fitted out, and that we may be able to access, and we are working with STH and ICB colleagues on that. So there are some practical things we can improve also, as well as the system flow pieces.
Thank you. Do you feel that more units like yours in other places in the city would be a benefit? So more unscheduled drop-ins located in, strategically around the city?
I'll answer that as an individual. So as a GP and as someone who's worked in sort of systems across the UK now for probably about 7 or 8 years, I think the answer is probably yes. I think we need to see a change in the way that we look at primary care. I think there is an unmitigated need for people to access same-day services. I think we're trying to accommodate that within services that they shouldn't be attending necessarily. So there's a huge amount of pressure on general practice. I've sat in sort of system calls and system meetings which are not in Sheffield, and we've talked around sort of access in general practice being more than it has ever been, but still not solving the problem. And I think the only way that you can do is we need to look at the people's need for access of healthcare to be completely separate to their general practice experience of healthcare, which is about managing people over their lifetime, not managing them on a day-to-day basis. And I think that needs to be separated. I think that is a real shift in need that is the difference between the 20th century and the 21st century. That general practice used to be the people you go to if you had a cough and cold. General practice now needs to be the people that keep you well and prevent you from having disease. But then there's still people, you still need to see someone about your cough and cold, and that shouldn't be A&E, because A&E needs to be, a consultant once said to me, A&E needs to be the place with the sickest people and the most expensive pieces of equipment. And so it shouldn't be an overflow for people who can't get their access in general practice, but we need to reflect on why people can't get the access in general practice and create something new for that.
Thank you very much. Same comments I've heard from a number of GPs that I've spoken to. Definitely shared views on that. Were there any further questions? Mary, did you have another question?
Quite interesting how this conversation has now turned about how we access, how healthcare should be delivered and what we access and when we access it and what can you manage at home. You know, perfectly, a cough is not necessarily a thing you need to go to your GP for anyway in the first instance, is it? But just like last question, how many of your clinicians is their sole job with you, and how many have second jobs?
Just on the point around, I think that there is around sort of patient education. I think we've been trying to educate patients, or what we call educate patients, for a long time and trying to change the behaviour, and we haven't. So I think there probably needs to be a cultural change on our sides as the NHS, more than the actual people. I think last time I'd said about educating patients, someone from the sort of very senior GP told me off and said, most people know what they should do and where they should go, so it's about empowerment and advocacy. So people are not going to A&E because they love going to A&E. They're not coming to the walk-in centre or their GP because they want to go to because they have a need, and we need to respect and understand that. We attempt to be fully employed. What we do, we will have locums who work in our service. The nature of urgent care is that you tend to get much more portfolio and locum workers, so they tend to. So even the people that we do have fully employed will do locum sessions elsewhere. What we do make sure is, and what we ensure and demand is that they stick within the European working time sort of regulations. So we don't want people working sort of 80 hours a week because we know that's unsafe. So what we do is monitor how many hours that they do work, and we do have a requirement that people disclose that to make sure. And that's not because we don't want people to go off and earn more money and go work elsewhere, but it's just about keeping them safe and keeping patients safe.
I really want to thank you for your time today, and it's probably longer than you thought you'd be here, so thanks for answering all our questions so comprehensively, and I know we'll stay in touch about how things are going. We're asked to note the update, I think, members. I've lost the page. I'm going to ask members, would we like to receive any further formal update from the walk-in centre at some point in the future, just to see how the improvements have been completed and what position you're in? 6 months? Where does 6 months take us?
guess potentially as
That's
needed.
purdah, but
I guess potentially as needed as well, because isn't the re-review by the CQC?
Yeah, I mean, what we can do is when we do get the CQC report, obviously you'll see it, but we can contact yourselves then around an update from that. And also, Lucy, quite happy to kind of contact you out of this from a Health Watch point of view and just get your involvement a bit more.
thank you. Well, if we can note then that we'd like to hear back from you at some point in the future, whether that's related to CQC or not. I think it's just such a key service for the city. I think it's really important that, you know, we're able to support you as well.
What I will do is take away the requests around the demographic data and heat map sort data around the geography and also around the turnover of staff, and just share that back with you as well.
Are members happy with that? Thank you. Thanks very much indeed for your time. And that takes us on to our winter plan proposals, which Kate has come to present on. So welcome to you all. If you'd like to introduce yourselves and your roles, and we'll hear your presentation. Thanks.
Good afternoon, members. Ian Atkinson, Deputy Place Director for the Sheffield Place team within NHS South Yorkshire ICB.
Hi, I'm Kate Gleave, Deputy Director for Children, Young People and Urgent Care for Sheffield Place at the ICB.
Afternoon, I'm Michael Hopper, Chief Operating Officer at Sheffield Teaching Hospitals.
Hi everyone, I'm Greg Hackney, I'm Senior Head of Service and Deputy to Director of Operations at Sheffield Health and Social Care.
Okay, thank you, Chair. So there's a couple of items that follow on quite nicely from the discussion earlier. Colleagues are just going to talk through the developed winter plan. I suppose it's a surge plan as we talk these days in terms of the continued pressure that the NHS finds itself under, but we wanted to share with colleagues the real high-level view of the plans as we're running into winter for this year. And then I know members have asked for a bit of comparative analysis on the demands on the NHS in Sheffield from an urgent care perspective, pre-COVID and post-COVID, and how we recover from that and the challenges which we've heard about, some of them, Chair, in the previous discussion. I think before I ask Kate just to run you through those slides, I think the point on pressure and challenge in the system, it's absolutely here, it's absolutely real. We've heard some of the challenges coming through one element of urgent care, and we'll kind of reflect on those as we work through. So in previous years when we've talked around planning for winter, you might have seen a kind of reduced demand on a system throughout the year, and we gear up for a busy January, February, March time. Those pressures are absolutely intense and challenging across the footprint pretty much at the 12-month period. So it's just that context that I just thought I'd share with colleagues. And if we can, just a bit like we've done with walk-in centre colleagues, those frontline staff that are working in this space, it's a really challenged area to be working in, and we thank them for all their continued work on that front line. So if I just hand over to Kate, and then we can get through the slides. Thank you.
Okay, so in terms of the summary of the winter plan for Sheffield, we are going to just cover kind of what's our starting point as we go into this winter, what we're doing to improve urgent care, and just give you some highlights of some of the things that we're focusing on, some ideas of our key milestones, and then just a little bit about how we're doing this. I would say there is a much more detailed plan that sits behind this, that's quite technical, which is why we've not shared it with you today. And equally then, each of the providers have their own individual winter plans that are more specific to their own organisations and what they need to do. So in terms of what our starting point is, you will see from the other set of slides that I'll talk through in a minute that we have got differing levels of demand across different parts of the urgent care system within Sheffield compared to pre-COVID. So the walk-in centre is generally seeing lower levels of activity than pre-COVID, but the hubs and the general practice collaboratives, so the out-of-hours service that's up at the Northern General, is seeing significantly higher numbers of activity. 111 is also seeing more activity than pre-COVID. The A&E demand at both the Children's Hospital and STH is now coming back down to more in line with pre-COVID levels, but certainly at points last year, the demand there was at both hospitals was significantly higher than pre-COVID as well. I'm sure you are all aware that different parts of the system are all reporting seeing patients with much higher acuity. So all that means is that they are sicker than they were pre-COVID, but also patients are more complex. So they are coming either with more conditions or those conditions are more tricky to treat because of some of the kind of wider needs of those people, as Will's talked about in terms of some of the examples through the Wellbeing Hub. And these take more time to see and treat, fundamentally. So as an example, YAS, the Yorkshire Ambulance Service, are regularly attending significantly more what they call Cat 1 calls. So those are the calls for the most life-threatening patients who need to be responded to within 8 minutes. They are seeing significantly more than they're predicted day in, day out, nearly every day in South Yorkshire. So we are really feeling that increase in acuity and complexity. I think Scrutiny Committee has previously heard some of the updates around some of the challenges that we face as a system around discharge in order to enable patients to get home more quickly from both hospitals, Teaching Hospital and the Health and Social Care Foundation Trust. And you will appreciate some of the implications of the ongoing strike action across all of our providers and the impact that's having on urgent care as well as the planned care. In terms of thinking very specifically about this winter and what we anticipate might happen, which I know is a bit of a crystal ball gazing exercise, but what we are planning on is that we will have what we call normal levels of flu within the city, normal levels of scarlet fever, so absolutely not hopefully seeing the levels that we saw last year, and normal levels of respiratory syndrome virus. That generally impacts on children first, and then adults tend to kind of pick up a little bit later in the season. We also think we will see COVID levels like last year. What we are anticipating, though, is perhaps an increase in norovirus, so diarrhea and vomiting, particularly, resulting in hospital attendances, largely because we think people are less less conscious of washing their hands. So that is likely to spread more prevalently than it has done in previous years. So that is some of the intelligence and some of the factors that we're working with, and all of the providers have used that intelligence to think about their workload and their staffing numbers and capacity in terms of what they need to progress through winter. So in terms of what we are doing to improve urgent emergency care this winter, fundamentally it boils down to we are continuing or restarting schemes that we tried last year. You can just move on to the next slide, please. On top of that, we are implementing kind of additional schemes and new schemes this year. So all of those things that we are doing, we'll do one or more of these three. It will either provide a service at an earlier point in the patient's journey, because we know that for a lot of people those journeys are too long. It will direct patients to a more appropriate service that is better able to meet their needs, and or it will increase the capacity of services. So just as some examples, in terms of providing a service at an earlier point in a patient's journey, so we have now got an under 11s clinical assessment service. What that means is if you are a parent ringing 111, you are not left in the queue waiting for a healthcare advisor to get back to you. You will be routed directly to the out-of-hours primary care service if it is in the out-of-hours window. And that means that your patient journey will be sped up considerably, because you will speak to and potentially see a clinician much quicker than you would if you'd have gone through the kind of the normal 111 route. So that's been operational for 6 months so far, and they're seeing an average of 130 calls per month go through. And we know that traditionally that is one of the reasons why parents choose to take their children to the children's A&E, is because they might have started by ringing 111, but they feel they're having to wait too long to get to the end point, so they choose to take the children. So we know that that's having an impact. An example of something that we implemented last year and have just restarted is something called the acute respiratory hubs. So these reopened on the 1st of October. Initially they'll be based this year in Darnall and in Fairlawns. And these provide additional primary care capacity to see and treat acute respiratory illness, which is one of the things that's particularly prevalent throughout the winter. So patients can be diverted there by Sheffield Children's Hospital, by a patient's own practice, or by the out-of-hours service. And that means that some of these patients will be seen more quickly. So potentially if they went to the Children's Hospital, the wait can be quite long there at times, and so it means that they'll be treated more quickly if they're able to get themselves or be transported to Darnall or Fairlawns. But it also means that the service is respiratory specific, so potentially they'll get a more tailored solution for their needs. In terms of directing patients to more appropriate services, so we are developing pathways for what we call direct conveyance. All that means is that an ambulance, if it's required, can take the patient directly to the specialty or to a ward that they need to go to, rather than taking them to the emergency department or the A&E, and then that patient having to be then transferred after they've been seen in A&E. So, for example, we have now got direct access to the early pregnancy unit. So that means if a woman is bleeding heavily, or is suffering a suspected miscarriage, or is having really bad morning sickness, and they need kind of a hospital assessment, they can go directly to the early pregnancy unit rather than having to go to A&E, go through that process to then be passed on. An example of increases in existing service capacity is the expansion of the number of patients who will be able to be cared for on what's called virtual wards. So this is a concept where a patient who previously would have needed to remain in hospital to have their condition monitored and treated can now return home to their own home and continue their monitoring and treatment under the care of the hospital team. Patients who previously would have needed to be admitted to hospital in order to have some monitoring or treatment will also be able to be cared for under that virtual ward. So they won't even, for some patients, even need to go into hospital in order to have that monitoring and treatment. Another example, before I just move on to the next slide, is the mental health emergency response vehicle. So this is a car that is driven by ambulance staff who have had additional mental health training, and it's something that's already been rolled out in other parts of Yorkshire. So where it's already been rolled out, 61% of the calls that that vehicle and crew attended were able to support the patient at home or provide the care they needed with a community partner rather than transport them to the A&E department. So again, we're hoping that this service in Sheffield will have a similar impact in terms of being able to avoid patients having to go to the A&E department and provide them with the care and support they need in a more suitable environment. So if you go to the next slide, we've picked out a couple of our key milestones that range through the winter to give you an idea of what we anticipate will come on stream at which point, and an example of the impact that we think those actions will have. So I've talked about the mental health response vehicle and the acute respiratory hubs. There's a range of investments around mental health services that are designed to reduce the length of time patients with mental ill health will remain in a hospital bed. So they include things like a dedicated social work capacity, working into the care trust inpatient wards. We will have some what we call somewhere else to assess beds that are mental health specific, so tailored to the needs of that group of patients. We've got more mental health liaison staff working within Sheffield teaching hospitals, so that will enable more timely mental health assessments in the hospital wards as well as within the A&E department at STH. And finally, we have got additional voluntary sector capacity to support post-discharge arrangements for patients with mental health needs, which will help increase the options and the support that is available for them. So in terms of how we are going to implement all of these things, again, there's an awful lot of work going on in the background, but I thought just from a kind of a summary perspective, At an operational level, information about service capacity and demand is shared on a daily basis between partners, both within Sheffield but also across South Yorkshire. And provider colleagues are working really closely together to help manage both the individual patient experiences as well as supporting staff wellbeing in terms of providing some what we call mutual aid. At a transformational change and a more strategic level, all partners are also working together to implement some of the longer term improvements that we know will not only support the system this winter, but over the longer term as well, so that again, by next winter, we should be in an even better position. And I'll leave it there for questions.
Thanks very much indeed. While you're having a bit of a think, I'll kick off with one that immediately comes to mind. So, Kate, you've described some really, it sounds like some really good practical measures that are going to speed things up for patients and going to alleviate pressure in some of the hardest places. So, how much of what you've described there in terms of some of the additions and improvements, like new mental health social workers and specific space for mental health assessments, and virtual wards, I presume that's to help with discharge, speedy discharging. So all of those things sound brilliant. Are any of those only for winter, or is actually all of this intended to be longer term?
Thanks, Chair. So in terms of specific examples of virtual ward, this is something that is coming online. It started coming online earlier in the year, and we're ramping the capacity up to optimise ourselves over winter. We'll then evaluate the success of virtual wards. So in the first instance, they are on what we class as a non-recurrent as opposed to a recurring budget. So if the evidence stacks up that they have one, supported discharge out of the hospital setting, and two, hopefully avoided admission, we'll then consider a case for recurrent funding down the line. But in this first instance, our view would be 12, 18 months, possibly 2 years worth of funding in that space. In terms of the mental health element, Greg can comment further if we want to delve into that space. For the investments across liaison, which is around the crisis support at the front end of hospital, the work around mental health discharge, hospital discharge, social workers, that is a recurrent investment into the system to support the demand that we believe will be in the system for a sustained period of time beyond this winter, Chair. So two slightly different approaches on how we're planning to fund those elements, but both will have robust evaluation behind them. Okay, thank you.
Councillor Lee.
It's about the Darnall service. People will be referred down to the Darnall. I think it's like the Clover practice in Darnall. Yeah. So how then will people in Darnall be affected by that who would normally access that service? Because it is difficult to get an appointment as it is. So that's one question. So I'll take that one first, if that's all right.
So it should have no impact on the patients within the practice, because it's a service that's been commissioned and will be delivered over and above the existing service levels. So it's additional staff that don't work in that practice providing that service.
Okay, that's interesting. I'm just going to ponder what will happen when people see. It's a good idea, it's a great thing to do, but you know, people will walk in, be seen straight away, where others are just waiting and waiting and waiting to be seen. But anyway, that's another issue to think about for us. And just about the...
Could I just come back on that?
Yeah.
So the acute respiratory hub, it was something that we actually trialled last winter on the back of large prevalence of respiratory that we were talking around earlier. So this is where we are signposting individuals into the primary care estate, but it is in effect two different services to the practice versus what is in the... So we triage patients either out of the Children's Hospital or via the wider out-of-hours GP collaborative. And we had really good access to that capacity at the peak of respiratory illness. We also had some really positive patient feedback as well, Councillor, in that space of people that we could get into a really timely appointment, predominantly of an evening time. So we're just expanding that opportunity for this winter. So I just want to give you the assurance there's quite a good evidence base there for how we've accessed it last year into this. We'll obviously keep evaluating that, but I take your point around if you're trying to get into the GP practice in that space versus the extended access that we're providing. But it's more around the use of the estate that's available to us there. Thank you.
The question is about the Yorkshire Ambulance Services response vehicle. A few years ago in Sheffield we had something very similar that ran all year round, where it was a CPN. I can't remember how many staff were involved in that team, a very small team that would respond to mental health emergencies, go across the city, deal with something on the spot, and refer on and do whatever they needed to do. So I take it that's gone, and this is something that's now introduced just for the winter.
Thank you, Councillor. So that's a really good point. So a number of years ago, we started an initiative with South Yorkshire Police called the Street Triage Programme. So this is slightly different, but we are wanting to work in partnership potentially with the police as well. This initiative is with South Yorkshire Ambulance Service, not the police. The Street Triage Programme is still running actually in parallel. I've actually got a meeting in a couple of weeks' time with the Partnership Director for Yorkshire Ambulance Service, a chap called Adam Leyland, and with South Yorkshire Police to think about how we can bring the two initiatives together to have a joint response. So at the moment there's two simultaneous programmes underway. But that actually demonstrated a huge amount of success in terms of the police street triage programme in diverting people away from emergency departments. So we do want to take the learning from that as well as the mental health review vehicle in other areas.
Just a follow up on that, because people might phone the police or they might phone for help, or they might not. They might just turn up at A&E anyway. What happens then? Because there may be a number of, and I've been up to A&E and spent hours waiting to be seen, and there's lots of people I know will have had mental health problems or some kind of mental health issue in that waiting room. They're waiting as well for a long period of time at the moment. How will that prevent that, or will it just be an additional service to the A&E service, because people will just turn up anyway?
Yeah, absolutely, and unfortunately we can't always prevent people from turning up at ED, and we've talked a little bit earlier about whether or not that is justified in order to prevent people either. What the Street Triage Initiative was trying to do, and what the Mental Health Review Vehicle will try and do, is to provide a more immediate offer of support to people within the communities where they live or where they are at the time. So for example, from my own clinical experience, I've been out with the police and supported people who present in crisis. The way the system has worked previously is somebody might ring 999 and say, I'm really unwell. I would attend as a mental health practitioner and provide support to them in their own home or wherever they are, to avoid the police feeling the need to take the person to an emergency department or a health-based place of safety. So it is a much better use of resource in avoiding the distress as well caused to that individual in having to be conveyed to a hospital setting. Obviously, we do all that we can to educate one another and support that system working between providers, but very often the police or the ambulance are not necessarily the best place to make that decision of whether or not it is safe to leave that person in their own home or in the community. And that's really what this initiative has shown to have benefit in other parts of Yorkshire where we've begun to roll out the mental health review vehicle. I think Kate mentioned around 63% of people we've been able to provide an alternative service in the community or in their own home, as opposed to taking them to the emergency department. So the intention is to deliver care upstream and avoid more intensive support that isn't required. And as you know, unfortunately, some of our physical health facilities are not necessarily the best place to provide a mental health support to people, and so we are trying to think of alternatives to that.
Thank you. I've got Lucy Davis next.
So I just wanted to pick up a question about some of the different routes that people might be able to access help a little bit earlier. So you've described obviously the acute respiratory hubs and the under 11s clinical services and so on. So it sounds really excellent that there are those different options and people could potentially get support at a better time, at a sort of more immediate sort of source of support for them. Just sort of reflecting on some of the sort of people that we speak to who are particularly struggling to access primary care, and some of the conversations that we've had around the hubs, which I know is slightly different, but I think I'm just wondering whether or not some of those issues might play out again a little bit with some of these other services, because sometimes we hear from people who haven't been able to get to that service, and it seems to be hard to get to the bottom of, but sometimes it seems to be about sort of different approaches taken, for example, in different GP surgeries as to when they might offer those other options out, or sort of signpost people in different ways. Sometimes some people know to ask for those things very directly. People might know about the existence of the out-of-hours hubs and ask for those appointments, or if we can give them that information and they know to ask for that, they end up being able to access support in a timely way, which is great, but it leaves some people obviously not able to navigate those things in the same way, which you'd hope everyone would receive an equitable service, but it's then very dependent on that very equitable approach across the sort of different agencies that might be signposting down them. So where I'm getting to with this, it's not in a bit of a long roundabout way, it's just a sort of question really about whether you're going to be collecting data on who's managing to get to those different places to identify whether there are sort of either sort of demographics in the city or geographical locations in the city where people aren't managing to get down those routes in the way that other people are, whether that be part of what you're looking at.
Yes, in short, absolutely, because we need to learn from what's working and what's not working, and we've seen some of that play out through some of the changes that we've seen since post-COVID. So thinking about, although it's not in the slides, but we talked about, we've seen changes in who accesses the minor injuries unit as a result of some of the work that we've done to kind of better publicise the role of the minor injuries unit and what it can do, and really engage with particular communities around that. So yeah, we're absolutely continuing to monitor it.
Can I just come back on that as well, Lucy? I think there's an important point, not just around how people signpost patients down, but actually the communication that we land back into the system to inform both professionals and patients of the services that are available over winter. So as part of our winter plan, there is a communications element that we'll take forward within that. I think we'd also welcome input from obviously Health Watch and other members actually to help us cascade that into your constituent areas, because that is something that year after year, trying to get the consistent messages out to the public around what is available, what you can get out of your pharmacy, what you can get out of different parts of the system is something that is a challenge year on year. So we do also welcome that support. I know you'll give that to us, but there is something around working continuously at the messaging out to patients to help them make informed choices. Thank you.
Thank you. Yeah, I should have emphasised it wasn't just about monitoring, it was about the actions that you can take to, so that's pick that up. Thank you.
I think on what Lucy's just said, I stumbled across on a GP practice website the relevant information, the signposting. It's on their opening hours page. So just sort of I looked at a couple of others, and it seems to be a little bit haphazard how that information is presented on practice websites. There might be a bit of work that could be done to make that more uniform. Like some websites have a pop-up, which is really relevant to whatever's happening now. So if you're talking about winter pressure, you could have a pop-up that has the correct signposting on to deal with whatever pressures are current. But it doesn't seem to be at all uniform across different practices.
Can I come back on that, Chair? I think that's fair feedback. Actually doing some work at the moment across the 75 practices in the city around website content. I know Lucy and colleagues at Health Watch did a really helpful report, which was also coincided with some intelligence that we were getting from patient feedback around consistency of information on practice websites. I know it's slightly different to the discussion today, but within our primary care team, we're actively doing that piece of work with practices to ensure that we've got the standard core information across practice websites, but then also we can use that going forward with practices to ask them to input information onto them, because we don't hold that kind of the ability to update individual practice websites, but we are doing that piece of work concurrently. And again, happy to feed the outcome of that to colleagues, but it was really helpful from Health Watch to kind of share that information with us. So thank you.
That's good, thanks. Councillor Phipps, I think.
Thank you, Chair. It's just a question around the milestone on patients needing support from health and or social care to go home from hospitals can do so without delays. I mean, that's a great achievement and something that has affected hospitals for a long time. I'm just wondering how is that being achieved? Is this through standard winter protocols, and does that involve maybe people getting sent to care homes instead of having care packages in place, or is this about a longer term piece of work coming into place? Because I know the council has been working with the NHS on this, or is this something to do more specifically with NHS social care? So basically I'm just wondering, that's a great milestone, how are you intending to achieve that?
I can come back on that as well, Councillor. So there's two things in this. Firstly, when I think I always get the words wrong, but the Adult Policy Committee, when we signed off the joint discharge plan, within that, under our Pathway 1 work, which was around discharges that involve social care and like, we talked around having a reception service and a hub to pull patients out of the system. That reflects that piece of work. So that's an ongoing one. Within the winter plan context, that's a component part of the winter plan, but within there we're also ensuring, I know members might be in around this through the Adult Policy Committee, the relevant capacity in our home care hours and the availability of 38,000 home care hours as part of the winter plan. So it's absolutely what you were reflecting on. It's part of our city-wide strategy to improve flow and discharge out of the hospital setting. And it's that work coming together that we feed into the winter plan.
And just to build on what Ian said there, so in terms of as a city, it's Ian, myself and Alexis Chappell that are working on that and have members of our teams delivering on that ahead of winter. Working back up the pathway, we've then got a programme focused on flow within STH, which is very much around understanding when patients arrive with us, what's their likely discharge date and likely needs on discharge, and building on the evidence nationally that if we can plan that earlier in a patient's journey, if we can link in with what's available in our community services within health as well as the wider social care services, we can get those patients on the right pathway and work with the families to plan that discharge. So there's some significant work we've had to do internally to improve that. Some further work we've still got to do this year, but absolutely dovetails into that work that Ian's described that's working at a city level.
Thank you very much.
Nobody else. I wanted to just ask a bit about infection control and what we've learnt through COVID and how that learning is actually present in healthcare settings and in communities and in schools. And it seems there's no particular strategy across the board about informing people about the importance of hand washing, about providing hand sanitizer stations in public and communal buildings, or about advising face coverings. So again, I've sort of drifted through a couple of GP practice websites. One says wearing face coverings is recommended in GP practice for all patients with respiratory conditions. Another doesn't have anything about it. I'm just wondering really where we're at with that, because we did promise ourselves through COVID that we would learn all these lessons, and we now seem to be in a position where there isn't any very visible public health education or message out there about that, and it does seem to be quite a big part of winter management, infection control. A lot of what we talk about is infectious diseases, and so I just wondered really what's being done about public messaging and education and continuing the good practices that we all adopted so quickly in COVID, but we seem to have forgotten. And you know, you walk into a public shared space, there may or may not be a hand sanitizer that's actually kept full near the door. It's all very haphazard. you know, pubs as well, places like that, restaurants. It's not very consistent. So I just wondered what your views are about that and what we're actually able to do in terms of educating and messaging and providing the relevant equipment.
Yeah, I can comment from a STH perspective on what we're doing internally. I'll hand to colleagues then in terms of the kind of wider community. So within the Acute Trust, a lot of learning through COVID, and particularly from our microbiologists around the management of prevalence and particularly reducing nosocomial infections, so infections between patients and staff and patients whilst they're within hospital. So we set up through COVID a tiered system around the community and hospital prevalence of COVID, monitoring the number of infections amongst patients and staff, and using that to indicate about when we put in certain measures and controls. They are around mask wearing in clinical areas. They are around at the highest level separating out COVID and we isolate patients with COVID and other respiratory viruses, but through the peaks of COVID over the last 3 years, we've had COVID dedicated wards. The higher proportion of patients in hospital are those who are in for something with COVID as opposed to in hospital for their COVID symptoms. But again, as we see the numbers of COVID increase, we will see more patients coming in with primary COVID reasons and how we manage those within our infectious diseases. So within the hospital setting, absolutely, that involves good hand washing, availability of alcohol gel and masks at entrances, and when required, moving to mask wearing in clinical areas. We had a conversation in our exec team ahead of winter around that can sometimes be challenging, and we often do things like non-face-to-face meetings for non-clinical practice as well in the organisation. That can sometimes run contrary to what then happens in the wider public, as you say, in bars, in social aspects. And so sitting that within the wider public health context can sometimes feel at odds for patients who can go into one public setting and mix and mingle without anything, and then come into a hospital setting and be under a number of restrictions. And we've said it's very important that we manage that across Sheffield within the Children's, the Adult Trust and Sheffield Health and Social Care, and then within South Yorkshire as well, so there is some consistency of message there. So clear plans that we've got around those different tiers and what happens and what changes for each tier, set them within the wider health and public context.
To be honest, Chair, I don't think I can answer your question around the wider societal views on the policy on that space. I think it's probably more of a public health dialogue through the Director of Public Health to give a view. So I think, as Michael's described, I think within that NHS sphere, working within the national guidance in this space, I absolutely know that colleagues continue to work within that guidance, but that guidance has absolutely been relaxed in line with the wider society in terms of that space. So I don't think we can probably add anything further from that. It's more of a wider debate with public health, would be my view.
I mean, I think it's definitely a discussion in public health, and it's one that I'm having. You know, Greg Van is very willing to discuss that side of it. But I just feel like if there are certain measures that we all accepted in COVID were necessary for as much prevention as we could possibly manage of spread of that particular disease. But there are other diseases that spread via similar routes, and we're not doing anything about those. So it seems like we haven't actually learned the lesson. Now, obviously, it's very difficult to get to a point where mask wearing is mandated for anything, and you know, we've all experienced that, but recommending mask wearing is nothing like mandating it, and isn't as sensitive a subject. I just wonder why the NHS in general, and specifically locally, the things that are within your control, or the control of, you know, those who make those decisions in each setting, why there's not a decision that leans more towards advising certain measures more proactively and visibly?
If I may, Chair, so I think it might be helpful if I offered a slightly alternative perspective, just because obviously I'm speaking on behalf of a different organisation. Michael articulated, I think, very well the plans that are underway within Sheffield Teaching Hospital around infection prevention and control. I do wonder if there's more a case of making that more visible. So certainly within Sheffield Health and Social Care, we have stood up a series of arrangements in preparation for winter, and that is central to our winter plan around infection prevention and control, around advice both to service users who may be attending our sites, but also a communication campaign, an engagement campaign as well with our staff. So I think whilst there's two elements to this, we're talking about the sort of public perception of IPC and what we need to do to influence that. And as Ian mentioned, I'm not sure I can adequately comment on that. But certainly within our organisations, IPC is number one on the agenda, and I can say with absolute confidence we've definitely learned from the pandemic in terms of how we handle IPC and the severity of which we, the weight in which we give to IPC as part of our planning. If we can prevent issues coming into our services, then the other measures or mitigation that we have to stand up do not apply. So we're certainly all for front loading and trying to do all that we can to minimise the impact on our services. But I do take the comment, and I think we need to clearly make that more visible to members here and to the wider public.
Sophie?
Just leading on from that a little bit, and it's just jogged my memory for over the last couple of weeks, because I did have COVID and I work in a day service setting. I was told, I said, okay, I've got my test result, what's the organisation number? Because when you get your tests through your organisation, you have to submit your, and it's like, oh no, don't worry about that, you don't have to submit it. I do firmly believe that obviously good data means good planning, so from that perspective, that you may have people who aren't reporting their COVID tests or whatever to you. And I think Councillor Milsom was also just saying about inconsistency of data and advice across the whole of the health service. Particularly with our community and voluntary sector organisations, having that information clearly disseminated as to what the guidelines are and what we expect to make sure that we have that good data to allow you to plan going forward is really important. So I suppose it's a bit of a comment, a bit of a question about how we're going to make sure that all are on the same page.
So through COVID and more recently there has been national guidance around staff testing and patient testing, and very much over this last year that's reduced to a level where we've not had. So previously all hospital staff were lateral flow testing if they were symptomatic. We had a process then of testing through our labs. That has stopped based on the national guidance, and absolutely there is a move towards COVID in effect becoming part of the suite of respiratory viruses like flu and other things over the winter. So at this point in time we don't ask staff based on the national guidance to test if they feel they're symptomatic. If they're symptomatic and unable to come to work, then like we would if they felt they had norovirus or something like that, we would absolutely ask them not to come to work. But at this moment in time, if they feel well and then they would come to work. Where they work in particular areas, we do ask them to wear masks to protect the colleagues and patients. We know, and that's how I tried to describe earlier, as we see more and more prevalence of this across the community, which is hard for everything that you're describing in terms of we're not testing, so we don't know to what extent this is prevalent across the community, but we are seeing the indicators that it's rising. We will step up and do different levels of testing. We've started testing more patients where they are symptomatic internally. But at the moment, the national guidance is for individual trusts to determine what is most appropriate in their areas to do that. So there is that risk of inconsistency, but that's where we want to work, particularly at place within Sheffield, and if we can across system of South Yorkshire, so we've got some level of consistency there.
Councillor Lee?
Yeah.
Sorry, just to say, we'll move on from this to the last agenda item after your question, Mary, unless there's anything else really pressing.
Carry on. Yeah, just COVID aside, just out of curiosity, COVID aside, if COVID hadn't happened, would the amount of hand washing we did during COVID have made your life, would that make your lives much more easier, I guess, if hand washing was absolutely as prevalent in the population as it was during COVID? Does that make sense? Putting COVID to one side, just the general sort of mix of viruses we all have anyway in the world, would it make a big difference to your workload?
So I'm not a microbiologist, nor a clinician, nor a public health. I am a ops healthcare manager, but listening to the colleagues within STH, I think, you know, it's absolutely good practice. Hand washing is good practice, and the evidence is clear that it can reduce the spread of infection. My understanding is we saw an element of that increase through COVID, and then we've seen that decrease again. How that's had an impact on public behaviours now, and where we see the value of hand washing in our kind of day-to-day care, I'm not quite sure. And then what that means for what we've built up our resilience throughout the last few years to other things other than COVID and how we respond to that now, I wouldn't be able to comment. But I think that it does come back to that. There are some very basic measures that individuals can take that would limit that is proven to limit the spread of infection, and good hand washing is absolutely one of those. And anything we can do to promote that, like we did through COVID, will clearly have a benefit.
Just during COVID, we were asked to wash our hands constantly, practically, weren't we? Now we're all probably back to normal levels, I guess. Not that we're not washing our hands in the right times, you know. Just ask about scarlet fever, because I heard about this, it was on the increase last year, but to me scarlet fever was something that was almost eliminated, wasn't it, a few years, many years back?
Sorry, Councillor, I don't have a view on that. It's more of a public health question that I think just needs to, I think that was on the Keep Respiratory, wasn't it?
Yeah. Yeah, so the reference to scarlet fever was in relation to just thinking about the numbers that we're expecting this year compared to last year, in terms of whether it was previously eradicated again. Unfortunately, you haven't got a clinician on the panel today, so I don't think any of us would be able to give you the correct answer on that.
Okay, is that all right? Okay. So I'm not on the right page for the actions on this either. Deb, can you help me out? We're just asked to note the update committee. Is there anything else anyone would like to add? We're happy with that. Thank you very much indeed for your time. Don't know if any of you are staying for the last bit as well. We have our next item, which is we've put adult A&E performance position, but what we asked for was an update on across the urgent care services. So obviously we've already covered the minor injuries at the walk-in centre at some length, and obviously touched on some other bits as well, but I think you've got a few more bits and bobs to present to us, including on the minor injuries unit. So if we can keep it as brief as possible on the presentation, and then we've got enough time still for some questions.
Okay, so I'm going to start again. So I'm just going to cover how has activity changed, how have waiting times changed since pre-COVID, how we're doing at the moment against our 4-hour target, and just a little bit of information about our main challenges. So I'm not going to talk through the detail of the first couple of slides, but if you go to the next slide, this summarises kind of the detailed slides. So as you can see, and we've talked about already a little bit, the primary care hubs and the GP collaborative have seen significantly increased activity. So both of these services that provide activity out of normal working hours. We've talked about A&E departments and the 999 activity. And we've talked about the fact that all of the parts of the system are seeing patients with higher acuity and more complexity. So if you skip to slide 9, in terms of how waiting times have changed since pre-COVID, so changes in the volume and timing of presentation is definitely something that we have noticed. So we are seeing more in-hours minor illness activity presenting at both the A&E departments, for example, and the increases in acuity and complexity, as well as the changes in patient expectations that happened kind of during COVID. So, do you know the bit about you can order an Uber and your food will be here kind of within an hour, or you can order something from Prime and it'll be here today or tomorrow. That's led into the expectations about urgent care in terms of when you want a service. Generally across society now, it is anticipated that you will get that very much quicker than you would have previously. So in terms of the waiting times, you can see at the Northern General, more patients are treated within the first hour, but less patients are then treated within 1 to 4 hours, and more patients do wait over that 4-hour period. At walk-in services across the city, slightly fewer patients are treated within the first hour than prior to COVID. And that's due to a number of factors, most of which we've already talked about today, so I won't go over those in any more detail. And then if you skip to slide 13, so our main challenges in relation to performance, it's really complex. There's a number of issues at play, but if I was just to pick out a couple of kind of the biggest ones and try and summarise them. So we are seeing large volumes of patients with minor illness attend emergency A&E departments. We know that we have delays in ambulances handing over patients to the staff at the Northern General Hospital in particular. We know that patients are waiting too long to receive care sometimes whilst they're in hospital, and we know that patients sometimes wait too long to be discharged from hospital. In terms of how we are working together to address all of those issues, it kind of goes back to some of the detail of the winter plan, some of which are things that we've talked about being specific to this winter. And there are also a number of things that we've talked about already today that are kind of that longer term transformation, or will take time to implement as we progress through winter and out the other side into next financial year.
Thank you. Lucy, do you want to start off?
Yeah, thank you, Kate. I was just really interested in your sort of comment there about sort of change in patient expectation. And I'm sure there's all sorts of complexity around the sort of psychology of what people expect from health services or what they need at different times, that is probably far more complex than we sort of get into here. But just anecdotally, the sort of sense that I get from patients is very much not what you've described. I hear from people who actually have very low expectations of what they're going to get from, particularly from primary care, where there's almost resignation from some people. I sort of recall clearly a sort of series of conversations that we had in Firth Park with sort of some older people who were essentially telling me they'd given up sort of trying to see their GP because it was so challenging. And again, in relation to the walk-in, we were well aware that people were waiting a long time in the walk-in often to see a clinician, but actually generally people didn't complain overly much about that because they were resigned to sort of expecting that would be the case. So I guess I'm sort of just trying to sort of think, what is it that we're sort of saying here about patient expectation versus the reality of what can be delivered? And is it more about the frustration of always seemingly being in the wrong place for what they need? So, you sort of described a lot of sort of presentation at A&E with minor illnesses. And actually, is there something there about, it is frustrating, obviously, if you're having to wait in a queue behind people with, you come in with a minor illness, you will be waiting a long time, won't you? You'll be triaged to the back of the queue. So I guess it's not even really a question, it's really just on behalf of patients, really, I wanted to say I think it's maybe a little bit of an unfair characterisation of the kind of experiences that people are having, and that we need to sort of think about it in slightly different terms and reframe that sort of conversation slightly to be more honest about the frustrations that people are having and the impact that has on them. So yeah, sorry, I've just made a comment and a question. Sorry.
Thanks, Lucy. If I just come back on that, I think I take your feedback in terms of patient perception. I think there is something in your comment as well, which Will also raised in the walk-in centre in terms of the configuration of services and the model of how I'll use Sheffield as the example in this space, 75 GP practices, 15 primary care networks, a walk-in centre, 2 A&Es and a GP collaborative, and actually how that architecture's developed over time versus actually how do patients access all those different points that I probably just described. And that, I think that was probably where Will was going in terms of a dialogue in the city of actually what does same-day urgent care look like 5 and 10 years from now in the city, because it will probably look totally different to what it does now in order to meet some of those challenges that you're just describing in terms of where patients navigate the system. So I think your point's really well made on that.
Councillor Lee.
Can I just ask, I mean, I think you're absolutely right. I think people put off going to the GP, they've got a niggle, they've got a worry, but they think, well, I can't really go and I can't get an appointment anyway. So they wait until they've got something more serious to go with, and then they can feel as though they can insist. So I think that's happening a lot out there. But I'm just, as a result of COVID, a lot of, obviously waiting lists have gone up, but there's a lot of people who get called back to hospital for routine investigations. They're at risk from something. I don't know, it could be all sorts of things that they're at risk of having or developing, but have not developed it yet, but go back for regular checks to be monitored. Are we back up to speed with those regular investigations that people experience, or are we lagging behind? Are people still waiting?
So from an STH perspective, so our waiting list has grown from where it was pre-COVID. And when I described the waiting list, that's about patients who have been referred in and are waiting for their first treatment. So that might be first outpatient or subsequent outpatient to come to a diagnosis and a plan or treatment, so an operation or something like that. What we then monitor and keep track of are those patients who have had their first definitive treatment, but I think as you're describing, Councillor Lee, the kind of ongoing care. We track that because we know often that's how we keep patients well, is keeping track of their care and overseeing the care over the longer term. We have got some areas where patients are waiting longer for that, and we're tracking that, and it's part of our recovery plan as much as it is monitoring the front door and the waiting list. One of the national initiatives that we've been working with our clinical teams to implement is something called patient-initiated follow-ups, because we know in that long-term follow-up we can bring patients back for care, and it can add little or no value to the patient, and that takes up a slot for something that could have been better used for a different patient. Patient-initiated follow-up care, or PIFU as it's referred to, is about empowering the patient, being really clear through a clinical dialogue about these are the triggers that may mean that you need some input from us or you want some support from us, and here's a very quick and effective way of getting back into our service. So rather than us putting an arbitrary 3 month, 6 month, 12-month placeholder appointment for you to come back, you come back when you feel that it's appropriate. So we're slowly moving to that, and we think that's better, more patient focused care, and is more appropriate about using the capacity that we've got. But underlying for all of that, there's significant work going in about how do we get back to the levels of activity that we had pre-COVID, because you'll have seen that nationally that's been a real challenge for the NHS, is to deliver the levels of care because of workforce constraints, some of the infection control because of the demands on emergency care, and obviously this year particularly because of the impact of the industrial action. But how do we create more capacity so that we can bring our waiting list, both those at the front end and for the longer term care back down to the weights that we had. And I was always proud. I've been Chief Operating Officer for STH for about 8 to 9 years now. Pre-COVID, we were always top 5 shortest waiting times in the country on 18 weeks, and we didn't have any patients waiting an excessive length of time. So we're absolutely committed to getting back to those positions as soon as we can.
Okay, thank you. I've got a couple of questions then. So looking at the numbers, the table that you presented that shows waiting times and the number of presentations at the various services. I just wondered, is non-presentation something that's part of the picture as well? And obviously it's really hard to measure that. But there is, I don't know how you'd even go about measuring it, but we've heard also about the increased acuity of the conditions that patients are presenting with when they do present. And so is it the case then that people are avoiding even trying to get a GP appointment and avoiding going to the walk-in services because they feel they won't be seen? Is there an element of, a bit of giving up hope, and does that mean that people are presenting later on when they really feel they've got no choice? Is that part of the picture, and how on earth would you measure that anyway? But is there a correlation with the acuity and more complex health needs of patients when they are presenting? And do you know what effect there is of patients moving over to private care? Because you do hear that anecdotally a lot as well, and I don't know how that can be measured, and I don't know if Lucy and Healthwatch have any insight into that. But these are things that are very difficult to quantify and track down, but anecdotally you hear them all the time. And the radio call-in programmes, people say, I've given up, I've gone private, and I'm spending my life savings on medical care. So it's something that's happening, but do you know to what extent and what effect that's had on need and demand within the NHS systems?
So I can come in from an adult acute perspective. So I think it is absolutely, as you say, Councillor Milsom, difficult to track that unmet demand. We've done some work within Sheffield teaching hospitals. I know the Children's have done the same, and we've done it as the Acute Federation across acute providers in South Yorkshire about tracking health inequalities, and has there been any change on both our waiting lists and our emergency pathways to see is there something that's different now compared to before, and we can't see that in the data. So that doesn't necessarily reassure us that it has that doesn't reassure us about the unmet demand, but it looks like the patterns accessing our care have remained the same, and we continue to track that, and we're doing a piece of work across South Yorkshire to dive into that deeper, particularly on our planned care. And then within our emergency pathways, I suppose a couple of things to know. As we've described in the data, the walk-in centre demand is down, so there is capacity there that is available. And one of the big things we push within the city, particularly as part of our winter plan, is a choose well, which links back to some of the comments about how do we ensure that the public knows what services are available. And so the walk-in centre and the services that they offer, there is capacity there. We implemented last year, and it's embedded really well, and we've seen it in the impact on patients in A&E and elsewhere. Is we now have a streaming nurse within in effect, the reception area of the Northern General Accident and Emergency Department, which identifies at presentation those patients who can be diverted to the GP collaborative on the Northern General site, or the minor injuries service on the Northern General site. So where patients do come, and I think you can see that in the data, those patients that are being seen under an hour, we're getting them into that service. If they've not if they've not known how to access care and they have turned up at an accident and emergency department, we've streamed them out to the most appropriate service that we can at the time as soon as possible. And then the third thing is linking back to the conversation around those patients that are known to STH because they've been referred on a waiting list or they're under a planned care basis. We know that we see a number of those patients whilst they're waiting access emergency care because they are waiting for their planned care, and so we are talking to the clinical teams about linking to the patient-initiated follow-ups, but how do we keep patients safe, how do we keep patients well, how do we track them and get them into the right services so they're not having to default to emergency pathways. So they're the three things across it. In terms of private care then, and I presume that will be on the planned care pathways rather than private emergency care. Again, I wouldn't know, we don't track that across the city as far as I'm aware, but our referral numbers are back to the levels that they were in 1920 pre-COVID. So we're seeing the same number of patients being referred for planned care at Sheffield teaching hospitals as we did pre-COVID. So that could imply that we're not seeing a drift of patients into private healthcare, but I wouldn't know. It's a bit like the unmet demand. It's how we track that and where we spot that. We wouldn't see that in the acute trust.
Mary and then Sophie.
I know a few years ago, you know, the health inequalities, you mentioned the health inequalities between the east and the west of the city are significant, and people referred themselves to GPs and therefore for further treatment much later, and outcomes were poorer. But everybody was trying to address that problem. Has that got worse since over the period of COVID? Have we lost the ground we made up? Did we make up much ground in the first instance, I guess, but is that worse? We must keep records of, and I'm just for my own curiosity, I'm guessing to the Social Health and Care Trust. How many people come from the east of the city, north east, and how many come from the west as inpatients?
Absolutely. I mean, I'll do my very best. I mean, I guess it's entered into the realms of perhaps more public health than provider, but certainly for mental health, we do know that people from more socially deprived backgrounds or a whole range of sort of, you know, deprivation can impact upon both the acuity and the prevalence of mental illness. We do still observe differences in terms of the rates of mental illness and severity of mental illness and the types of treatment that people require from different areas of Sheffield, depending upon a whole range of factors such as ethnicity and the list goes on really. In terms of what we're trying to do in mental health, I appreciate we're veering slightly away here from urgent and emergency care, but we are doing a lot of work within primary and community mental health with GPs. Very, very similar actually, or more of an iterative version of what Michael has described around PIFU is with GPs. We're trying to have a more accessible community mental health service because GPs are often the people that advocate for people with mental illness, to mean that advice is available at the point of need as opposed to some of the long community waiting lists that we've got at the moment. So that is a live transformation programme which will start to take effect from the new year. We should start to see from February as merging with some of the primary care networks across Sheffield and the GP practices within them. But I am taking us way off urgent and emergency care here, so thank you. Of course.
So, as I described earlier, when we've done the analysis of the waiting list, we haven't seen a change in the demographics of the patients on it. We need to do further analysis to understand that better.
Chair, if I could just come back, really good points around the northeast of the city, and within our health and care partnership, we've doubled down on the priority to target into that space again, Councillor. So we are doing a range of initiatives in there. I'm just reflecting on the discussion today, Chair. There's probably two things that are coming out. One, whether we just have a chat around the forward plan and whether we do something on primary care access and just bring that back through for a discussion. And then secondly, share with members the work that is happening in that northeast to kind of try to continue to drive down on the ambition to reduce health inequalities. That might be just something that we might want to pick up, because I'm just picking up those recurring themes out of the dialogue. We can absolutely pick up on that and come back to discuss it if required. Thank you.
It is the east as well as the northeast. If you think of where our lack areas are, the east is as deprived as the northeast.
Thanks. I just have I suppose, a workforce question within A&E in particular, based off of a recent experience in A&E. As I ended up there after a minor injuries visit following the 10K, and my first visit to minor injuries, got x-rayed, made sure that I hadn't broken my ankle. It was like I was in there and out really quickly, and then sort of sent home. As days went on, it got a lot worse. I did end up in A&E because it was after minor injuries would have closed at the time, and I knew I didn't quite necessarily need to be there, but I was in that much pain where I was thinking, actually, has this got worse to the point where I do? We had a visit out from the sister that was on duty at the time, which I thought was really, really helpful. It meant that we could all get to know what the waiting time was, and she was there to give us some advice. I found that really helpful and reassuring. She came in and gave us an announcement saying that, look, there's 100 of you in here. There's some of you that are minor injuries cases, but the person who deals with our minor injuries at the minute is off sick. So you're all going through the doctor pathway. And so it'll be another 4 hours. And at this point, we'd been waiting for 2. So my other half brought her over, and she made sure that I hadn't dislocated it, which was good, and said, look, I think it'd probably be best if you go and come back tomorrow, because it is obviously quite a long wait. But with that in mind, with just one staff sickness having such a massive knock-on effect, and making sure, and then channeling everyone into the same pathway, that is going to be something that is going to be, we're going to have increased pressure on A&E as we go into winter as well. How do we make sure that workforce planning doesn't, so that we have one staff sickness that's not going to have such a massive effect going forward? As I say, I did think that the way that the announcements came out was really good, and it made sure that I didn't waste any more of my time or theirs. And that's something, more of that, please. But overall, having that one sickness having such a massive effect, I think, is something to bear in mind in an A&E setting, I guess.
So really helpful feedback, thank you, and I'm happy to pick up outside if you'd like the particular shift, and we can dig into it and understand. The minor injuries stream, so we have the minor injuries unit at the Hallamshire and then the minor injuries stream at the Northern General. My understanding is that we don't rely on just one nurse within those streams. There's both in terms of it's a pretty large team of emergency nurse practitioners, so extended scope nurses that work within that and can work autonomously, linked into the department as and when required. So yeah, I think it is interesting, and I'd want to take away, why would one sickness, and it would be, I presume, a short-term sickness on the day, as opposed to, it's not to reassure you, it's not a single point of failure that if someone went off now for 6 months, we wouldn't have that service for the remainder for that period. But absolutely, the numbers that those staff see, the efficient way in which they can assess and treat and advise patients is such that if we lose some of that capacity, it can have an impact on waiting time. So sorry that you experience that. Can provide the details around the shift if required, but absolutely we've done the work with a number of our services, but A&E in particular, in terms of how to ensure we have the right numbers in the right different areas. What's the scope that we have within Sheffield teaching hospitals to pull more staff in? Unfortunately, when you have sickness like that, there's only a limited number of staff. We don't have those types of staff working in other areas of the department that we call on. We do have contingencies where we may, for example, pull on the orthopaedic registrars, because they would have that skill set to see those kind of things. And it sounds like the nurse streaming sister that I referred to earlier, I wonder if that's who came out and spoke to you, who will have been a senior nurse who can make some of those assessments and say, come back tomorrow when the service is on. So absolutely agree, it's really important, and we've done lots of investment, as I know other providers have, in particularly the health and well-being of our staff going into winter. We've talked elsewhere, and we see it in the national news around the impact of health and social care workers of COVID, of the recovery of the industrial action, and so we've described it as a risk within the city, and lots of work underway about how we support the health and well-being of our staff, because they are our greatest asset to keep on providing great care for patients, but particularly make the winter resilient. So it's a really fair point. But happy to pick up at the end if you want me to get some more detail on that particular shift, and that might just give it a bit more context. Thank you.
Just going to ask members if we're happy to extend just by 15 minutes to wrap up this conversation and make sure we've got time to deal with the work programme. Is that okay? I just want to ask, because the reason for bringing this item, which we've been discussing, I think, for some months about asking for this review of urgent care, was primarily the consciousness that there were proposals to relocate some of the services to the Northern General back in 2017. We all know there was a big campaign around it. The public opinion was very strong about not moving those, and the proposals were dropped. A couple of the contracts were extended then, the minorities unit and the walk-in centre, I believe, were extended, and then we've gone way past those periods. And it's sort of dropped out of public consciousness a bit. So in the spirit of all of that, and how precious the services are to people, and the strength of feeling back then about keeping them in the city centre locations, and the fact that they're still very well used indeed, in the spirit of no surprises, which I hope is the culture that we all want to work in, can you say to us today that there are no further plans to reconfigure these urgent care services? How far into the future can we look with security about the provision that we've got now, and things not having to go through that process again?
Thanks, Chair. I don't think I can say no. I think what I can say is that it comes back to the discussion with Lucy and what Will was saying. I think we collectively are of the view that we need to have a discussion to describe what our 5 and 10 year vision for same-day urgent care is in Sheffield, because of the demands in the system and also the architecture that we have within the system. So we will be looking at what those pathways of care look like, and I'd say within the next 6 to 9 months be wanting to engage dialogue with members around how that might be working through into our system. So do we have a plan now? No, we don't. Are we considering what the future pathways of urgent care in our city are? Yes, we will be doing that. But we'd absolutely, as you say, in the transparency dialogue, be having that with members at the appropriate point. That is not to say that we are making any proposals around architecture, where services are located, how they'll be delivered going forwards, but the demands on our system at the moment, as you've heard all afternoon, and the kind of changing of demand of patients following a pandemic, following the workforce challenges that we all face, for me to sit here and others to sit here and say all our system will stay in equilibrium as it is today for the next 5 to 10 years, I don't think we can say that. I think we can say that we will continue to look at the architecture in the city in terms of delivering same-day care. And what we mean by that is across the whole breadth of 75 practices, what that looks like for people that come down those urgent pathways that are currently in the city. And that's across GP collaboratives, it's across a walk-in centre footprint, it's across 2 A&Es in one of the biggest cities in the country. So I think what we can say is as soon as we're in a point to have an open dialogue around that and discuss it, we will absolutely be doing that with members and quite rightly bring it through scrutiny, but not at the end of the process. It's more of an engaged process. So I think the timeline for us, we have got contracts, as Colleagues from Care UK described, that are coming to an end, and we'll deal with those and share the outcome of that with colleagues accordingly. But we will be having the dialogue quite openly around what we think the future looks like for a fit-for-purpose urgent care offer in the city over the next 5 to 10 years. So going back to your point, no is the answer. I can't do that.
Okay, thanks. I mean, I think you've partly said it there, but I think I'd like to propose the members that we might recommend that, you know, as and when you start reaching that point of considering the future of all these services, that you do engage members, not just members of this subcommittee, but elected members who represent all parts of the city as early as possible in the whole process. And, you know, it sounds as though this is what your intention is, but, you know, in the spirit of co-production and, you know, and not the kind of consultation that is a proposal that creates conflict, you know, as we've had before, that traditional style of consultation, but in, you know, in a method of collaboration rather than that statutory consultation process, and actually, you know, some proper co-design with people who represent areas, but also people who use all the services. So I know those processes can get really rushed sometimes, but, you know, if we really think ahead far enough, it needn't be rushed and it needn't be high pressure. Are members comfortable with that as a suggestion? And that it should involve members wider than this subcommittee? Thank you. Any other questions? Okay, so brilliant. Thanks ever so much for coming today, and good luck with the winter plan, and hope everything goes to plan. It just leaves the work programme item, members, to consider before we finish. So we've got the work programme in the agenda pack at the end, and we have had a public question that relates to this. And I know that some members are keen to discuss another item that you'd like to put on the work programme. Thanks, Sam. So we had a public question. Yeah, okay, which is this, and this is for us to consider now, if we're comfortable to do so, in view of it comes in the form of sort of a request that we look into something and bring it to a future future meeting. So this is from a member of the public called Dave Berry, who says he's unable to attend in person. I'm aware of an occasion recently when the family member of an elderly patient at the Northern General Hospital felt pressurised when asked to sign a do not resuscitate form on admittance of their partner to the hospital. The family member refused to sign, but was then upset to find a respect form issued on discharge which they had not been consulted on and felt did not reflect the family's wishes. I'm concerned that DNR forms are becoming overused, and that protocols on consultation with the patient and family are not being followed, and that there is confusion regarding the legal status of DNR and respect forms and the required consultation required. I would ask that your committee ask for a report and consider this issue at a future meeting. The report may include information on the legal status of DNR and respect forms, copies of protocols regarding the two forms, training of health professionals in the use of and consultation required of the forms, and any statistics on the use of the two forms. Do members have any comments about that? Lucy?
Yeah, sorry.
So we've just been doing a piece of work around palliative and end-of-life care, and we haven't fully written up and shared the report publicly yet, but we have shared initial findings with the health services, and there was a strand within that reflected some of what you've just described. So I'd say it's something that we'd recognise as something that might warrant some further discussion and investigation. Did you want some suggestion as to where that could be targeted? So there is a particular project office that deals with the respect forms. So I think there's something about, there's the very specific routes and processes around, as you say, the respect forms and the DNAR forms, but there's also something about the kind of wider strategic picture of that, and the ICB is doing a strategy at the moment around palliative and end-of-life care. So I just wonder whether there's something about bringing in somebody who could give that kind of bigger picture, but also somebody who could give the more focused sort of information or response in relation to those particular forms, because I think the sense I get is that it's sometimes viewed as a sort of quite separate, isolated bit of that sort of bigger picture, and that I think it's useful to sit that conversation within a bit of a wider context and not just look at the forms and that very specific process, would be my view.
Thank you. I think that's very helpful, Lucy. Thanks. Mary?
I won't need to do that. I think I agree it does need to be looked at, I think, to see what the practice is.
Does anyone have a proposal about how we might take that forward?
I suppose I'm not sure it's one for a workshop as such. I think it's an issue that would possibly require a report and some questions being asked, really. Who attends that? I wouldn't have the knowledge of off the top of my head, but I think in terms of actually the procedural thing, I don't think a workshop would be the right environment for it personally. I don't know whether other members would agree with that.
So I think there's a proposal to bring it as a formal item to a future committee, and if Deborah could investigate who might be the appropriate people to communicate with about that. Yeah. Okay, thank you, members, and thank you to Dave Berry for submitting the question. Anything else for the work programme, Councillor Thornton?
Thank you. It's something that I've asked some questions on, and it appears that others have done the same, as some freedom of information requests have come out about the Sheffield Adult Autism and Neurodevelopmental Service, in light of how only 9 out of 21 people who've been seen have received an ADHD diagnosis, and that is 21 people being seen off of a waiting list of nearing 5,500. It's obvious, to me anyway, if a diagnostic service is only seeing 20 people out of 5,500, that's a diagnostic service that seems relatively, essentially non-existent. And I think the reasons why that's happening and how that's going to be improved going forward do need to be unpicked. So I'd like to ask for the Adult ADHD and Neurodevelopmental Service to come under scrutiny as a formal agenda item at a future public meeting of this subcommittee. So I'd invite a report from SHSC and the ICB, suggestion from Councillor Ayris from our conversations with Heather Burns, to attend that meeting.
Lucy, did you have a comment on that? No. Are you just waving your glasses in the air? Yeah. Okay, I mean, I'd be very happy to take that forward. Martin's nodding. Yeah. Thanks.
Can I just quick comment? Yeah, I mean, it's, the information is actually on the the Health and Social Care's webpage, Sheffield, for the Sheffield Adult Autism and Neurodevelopmental Service. So, and those figures have been updated in September. So, you know, the information is actually out there, and I was quite shocked that you know, that there was such low, you know, sort of the waiting times for people were quite incredible, to be perfectly honest. So I do think it's something that we have a duty as Health Scrutiny to, you know, to ask them to come in. And,
so I think we're asking for a report on the state of things as they are, and details around forward planning to set things on a better path. Yeah. Okay, and Deborah had a comment about the other item as well, I think.
Thank you, Chair. Yeah, it was the item that's been added to the work programme following the discussion at the last meeting on bereavement services. I just wanted to get some clarification on that. I spoke to my contact within Sheffield Teaching Hospitals about their perspective on bereavement services, what kind of bereavement services, and she talked about end-of-life and palliative care, and she also talked about maternity bereavement services. So those are two specific services that they would kind of consider to fall under that heading. And I wasn't sure whether that's what members were looking at when they mentioned bereavement services. The issue that I've got is that obviously this is health scrutiny, not any other services. It's got to be purely health scrutiny. So if it was a concern about bereavement services that the council runs, for example, then that wouldn't come under the jurisdiction of this committee. So I just wanted to get some clarification about what members wanted.
I was just going to clarify that there are bereavement services external to the hospital that are commissioned by the ICB, so I was just going to clarify that.
I think it was one that I raised, and I think we said that it would probably be more appropriate as a workshop discussion about the state of play as it is. It's something that I brought up as I don't believe it had come to health scrutiny for quite some time, just to see the state of play of how things are. Certainly, I'd been speaking to someone just as I was doing a delivery round, and she'd recently lost a parent and was having to clear out a council property extremely quickly and just did not know what services were available to access at that time. And certainly the services that she did know of had extremely long waiting lists and just didn't seem accessible. So from that perspective, it would be a more end-of-life and palliative. But, yeah, sorry, Lucy, if you wanted to come in. I'm trying to figure out how to end my sentence. But, yeah, I think it's something that warrants discussion. I don't think it's necessarily a clear sector for people undergoing it, and access is a problem as a result.
Yeah. So you're right, it's a really broad, obviously, area of focus, but I guess that I mentioned when we touched about on the DNL forms that there's an ICB strategy that's just being written at the moment about palliative and end-of-life care, and it is it's NHS-led, but it is meant to be quite a sort of broad sort of system, sort of not just focused on core NHS services, but actually that whole pathway for people both during if they're themselves receiving those services as part of end of life or care for bereaved family members and so on. So it would tie in quite like if you wanted to get somebody here to talk about that strategy, for example, there would be potential probably to do a bit on the respect and the DNR forms would sit alongside that item potentially.
Yeah, I agree. I think it could make for a heavy session, but
we're at time. I think we'll take that away and look at how to wrap that into something coherent and make sure the right people are involved in a discussion around how to bring that to an agenda. Can we leave that with you, Deborah? Thank you. If you've got further questions, direct them, I think, straight to Deborah. Okay. So apart from to say that our next meeting is to be held on I believe the 16th of November. That, members, is all our business. Thank you very much indeed.